I've
Very big.
demonstrated a workshop there some time back.
Yes, sir.
So, friends, good evening. We warmly welcome all of you for this postgraduate clinical teaching session, which happens all Friday. We warmly welcome the day's invited faculty, Professor Sanjay Singh from MLN Medical College, Prayagraj, Professor Nishikant Gujar sir from Vijaypura, Alamin Medical College. And we expect Professor Atri from GMC Chandigarh and Professor Gwalani from Mumbai, Navi Mumbai, DY Patil Medical College. So, friends, we have two important exam cases for the day, which has been quite some time being asked by the students. We have been working on more tougher cases. They wanted cervical adenitis as well as inguinal hernia, which are more challenging in the exams, and examiners are not very happy if basic cases there have been mistakes. So today we are going to have these two cases for discussion. And for that, the Professor Hitesher has kindly contributed Pooja from Narendra Modi Medical College, and she'll be presenting the case of TB cervical adenitis. Kanna sir, good evening, sir. So then Dr. Aranav again is a volunteer. In fact, he is from Rajendra Institute, Ranchi. And I remember recalling faculty from Rajendra Institute some time back. So I'm definitely we will take the cognizance of him and take more. Sandeep Agarwal sir, if I'm right, was there for some time with our
Yes, sir.
classes.
Yes, sir. Yes, sir.
Thank you very much. Give my regards to your professors for permitting you to present a case here. So, friends, we will be having Pooja to present the case first. Pooja, please introduce your unit chief, your head of the department, and then start your presentation. Good luck to you. I think you have been here with us sometime earlier also. So, the presentation goes history first, and then we end of it, they go back to the discussion, then clinical examination, and then they take you up for the other discussion. We warmly welcome Srinivasan sir. He was missing in action for quite some time. Thank you, sir. Welcome to the classes today. And if I'm not mistaken, Professor Gwalani and Professor Atri, are you with us, sir? In like phone numbers and few device names have come, if I'm not missing. Not yet joined. Professor Galani and Professor Atri, sir? Not yet. Okay. So, friends, you are welcome to share this invitation to your co-PGs. This is transmitted onto the YouTube channel also. You can just simply type Google PG Clinics and then it teaches you there. So those who wish to be part of here in the Zoom are welcome, and others can be watching in the YouTube. Good luck to you. Is that Professor Atri, sir? I could see someone joining us right now. Professor Galani? Okay, fine. So without much ado, we will start the session. Dr. Pooja, can you try sharing the PowerPoint?
Yes, sir.
Is Professor Atri and Professor Gwalani, sir, joining us today? Not yet in the group. Okay, I will try to reach out to them. But you start your presentation, and good luck to you, Dr. Pooja.
Yes, sir. Thank you, sir.
Right.
Good evening, everybody. Today, my case presentation is on neck swelling. I'm Dr. Pooja Jain, R3, final year resident, general surgery in Narendra Modi Medical College, Sheikh LG Hospital, Ahmedabad. And my PG guide is Dr. Hitesh Andharia, sir. I'll start my presentation, sir. Now.
Give me a moment. I think Professor Gwalani is here. Good evening, sir. Thank you for joining today. Fine. You can continue, Dr. Pooja. Professor Galani is just joined. I think he has to settle down. Faculty, please take over.
Okay, sir.
Right.
Yes, sir. Sir, I'm presenting a case of 44-year-old male, a laborer by occupation residing in Pali village in Rajasthan, came to LG hospital with the chief complaints of swelling over right side of lower part of neck since 4 months. Patient was relatively asymptomatic 4 months back, after which he noticed a swelling over right side of the neck on lower aspect 4 months back, which was insidious in onset, gradually increasing in size, not associated with pain. It was associated with low-grade fever 10 days 4 months ago, which was insidious in onset, and it was relieved on medication, which he took on OPD basis. There are no aggravating or relieving factors for the swelling, no history of any other swelling elsewhere in the body. There is no history of difficulty in breathing, cough, hemoptysis. There is no history of difficulty in swallowing. There is no history of change in voice, no history of drooping eyelids, or no history of loss of appetite or weight. In past history, patient is on AKT for extrapulmonary TB since 21 November 2023. He was diagnosed with pulmonary TB in 2020. He took treatment for 3 months and then abruptly discontinued it. There are no other comorbidities or operative history of this patient. In family history, his father had pulmonary TB in 2020 and took treatment for 9 months. In personal history, a patient is vegetarian with adequate appetite and sleep. His bowel and bladder habits are normal with no addiction. Sir, in general, in examination
Hello.
part, yes, sir.
What is your conclusion by your history?
Sir, my provisional diagnosis from the history is cervical lymph adenitis.
Okay.
Yes, sir.
Okay.
Go to
So
the
what
first slide, please.
Sorry, sir. Sir, on the history part?
Yes, yes.
Negative history.
Yes, sir.
What other swellings did you ask for?
If there is any other swelling in groin region of the patient or on the neck.
Does this neck swelling matches with your groin swelling? Any history which is in the groin, can you corroborate with this neck swelling?
Sir, if patient has lymphoma as one of the DDs, there might be a possibility that patient has multiple lymph nodal swellings all over the body. Cervical lymph
So
nodes.
where else you could have asked? Say you have mentioned about groin swelling, lymph nodes, groin swelling.
Yes, sir.
So when do you suspect that it's pathological for a groin swelling?
So I means to ask you whether it can be secondaries.
Yes, sir. There can be it
Look,
can be a
Dr.
secondary
Pooja,
abdomen.
Dr. Pooja, at a 44-year-old male with maybe a past history of COX with cervical lymph nodes, we will think more commonly of malignancy rather than straight away associating it with tuberculosis.
Sir,
Cervical lymph nodes in a 44-year-old, right?
yes, sir. If the swelling is, sir, mostly in supraclavicular region. On the left side, there are Virchow's nodes.
No, we're not talking about workhouse nodes, right? That's fine. Malignancy of the testes can present as secondary to workhouse, but I'm just saying it can be head neck tumor, it can be a gut tumor, it can be a tumor in the breast, it can be tumor in the thyroid region. They all can present with this kind of lymph nodes.
Yes.
So it's a short history of 4 months, right?
Yes, sir.
You can have what is known as CUP, clinically unknown primary, lymph nodes with an unknown primary, right? So we'll not jump straight away to tuberculosis, right?
Yes, sir.
Pooja,
So please.
Pooja, you are asked. There is no history. Go to the next slide, please. Drooping of eyelids. Why you ask history of drooping of eyelids in this patient? What you are suspecting?
cervical sympathetic chain involvement, if the swelling is big enough to compress or involve cervical sympathetic chain, so patient can have Horner syndrome, which consists of meiosis, ptosis, anhidrosis, loss of cilious spine.
Dr. Pooja, hang on.
Is it
The question
Probably
asked,
that is not the region.
Dr. Pooja, the question asked was, why do you ask for history of drooping of eyelids?
something of that?
Instead of saying cervical, sympathetic, you just say Horner syndrome. Let the
Yeah.
examiner ask you what is Horner's, and then you go on. You start off trying to show your knowledge that I know everything about Horner's, and then come back to Horner's.
Okay,
That's the wrong way of taking the examination. In
Okay.
examination, you should just answer what the examiners asked you. He's asked about drooping of eyelids, associated with Horner's. Let him ask you what is Horner's, then you give the answer.
Okay,
Right?
sir. Yes, sir.
But then beforehand, you should know also, Pooja, that whether you have seen Horner syndrome in such kind of swelling in the neck. Before putting your differential diagnosis of having symptomatology, have you ever seen Horner syndrome manifesting with such a swelling in the neck?
No, sir. It's
Okay.
it is
Okay.
So
How
the
can-
negative
how can this
history
be-
should be very relevant. Negative
Okay,
history
please.
should be very relevant. It is not that definitely it is the 44-year-old male. He's a middle-aged male having a cervical lymphadenopathy. You should always rule out malignancy, and then you should come down to a diagnosis of having a infective pathology.
Yes, sir.
First and foremost is ruling out a malignant pathology
Okay, sir.
for a 44-year-old male. And instead, going for Horner syndrome, you could have definitely bypassed this mentioning of Horner syndrome. Because if apical tumors of the lung, they manifest as Horner syndrome. And where do you find such lymph nodes?
Sir, in the posterior triangle.
Definitely,
Posterior triangle.
you have to have a mention of it.
Better not to mention it.
Okay, sir.
Yes, it is better not to mention it. It's not required.
Okay, sir.
One more point I want to ask you, Pooja. What is significant generalized lymphadenopathy? And what is significant lymphadenopathy? When it is called a generalized lymphadenopathy?
When two or more lymph node groups,
More
different.
than two groups of lymph nodes are involved. And what is significant lymphadenopathy? Just now, sir asked what about the inguinal lymphadenopathy size? More than 3 centimeter in case of cervical, more than 2 centimeter in case of inguinal, and more than 1 centimeter in case of axillary. That is called as a significant lymphadenopathy.
Okay, sir.
Like you should know why. Why it is said that more than 1 centimeter, more than 2 centimeters, more than 3 centimeters.
Sir, I don't know the why part.
The why part is that the lower limbs get frequently traumatized and they get infected. So you may get acquainted to so many villagers of people working in farms and not protecting their foot. They may have lymphadenopathy. But when you call those lymphadenopathy significant is when it is more than 2 centimeters. Otherwise, it is not significant.
And on one side, if it is larger than other side.
Yeah, definitely.
Okay, sir.
Okay, Dr. Pooja, like it was asked about drooping eyelids. So, and you said about tumors in the apex of the lung. What is Pancoast syndrome or tumor? Do you have an idea what is Pancoast?
Sir, Pancoast tumor of the lung at the apex of the lung, I know, and it presents as swelling. It can present as a swelling in the supraclavicular fossa, the fullness in supraclavicular fossa on the right side, and sir, syndrome.
Yeah. So you know what is a syndrome?
No, sir.
The syndrome is that if there is a defect in some problem in one system, there will be symptoms in another system also. So there's a defect in the lung, and it shows as symptoms in the brachial plexus. There'll be some problem in the brachial plexus. There'll be some problem in the cervical sympathetic chain. Right?
Yes.
So pancreas is one where it spreads along the ribs to the vertebrae, to the brachial plexus, and then causing horners. Sir, please.
Okay.
Pooja, if there is a upper cervical and the lower cervical lymph node is there, which
Okay.
one is more significant?
So lower cervical.
No, you're asking or you're telling? You answer.
Lower cervical is important. Upper cervical again because the infection, anybody having the oral infection will have the upper cervical nodes. But
Yes.
once there's a lower cervical, even if it is a centimeter size in the lower cervical, that is significant.
Yes.
Okay. Because if you are given a choice to take a biopsy in a patient who has got generalized lymphadenopathy having the cervical, axillary as well as inguinal, and it's a lower cervical is there, that is your choice.
Yes.
So technically that is the most difficult, but that is the choice to get the exact pathology.
Okay, sir.
Because the drainage is from upper to lower, right?
Yes, sir.
Now,
Sir,
this
please.
upper cervical node is there and there's a lower cervical node is there. What can be the change in the pathology in these two? What type of the malignancy will be there in the upper cervical and what type of malignancy can be there in the lower cervical? Usually, it can be either one.
Sir, in the lower cervical, it can be for due to secondaries, due to testicular carcinoma, or due to the breast, or due to liver and pancreas, or sir, in upper cervical, it can be due to oral cavity malignancy, pharynx or larynx generally, or head and neck tumors.
So what's the difference between the two tumors? Tumors in head and neck and tumors in the abdomen?
Pathology.
What type of the malignancy will be that in the lower cervical and the upper cervical? Origin you're told, but what type of the malignancy? It will be histologically what type of the tumor?
In head neck, what is the commonest tumor malignancy? It is squamous. And in GI?
Mesenchyme.
It's adeno.
Adeno.
Both the upper and the lower cervical lymphadenopathy has a different protocol of management. Malignancies, if concerned with the malignancies, they have a different protocol of management. So that is what you have to focus into. But for upper cervical, where you're thinking it's oral or pharyngeal malignancy of the pharynx or the larynx, they have a different, you go for a head neck dissection. But once it's a GI malignancy and you have a metastatic node at the lower GI, lower cervical lymph nodes, then the manifestation is different and the treatment protocol is absolutely different. So
Yeah,
that
Dr.
is,
Pooja, sorry. So, you've come to this diagnosis of tuberculosis. Tell us the points in history which you think will support your diagnosis of tuberculosis. What are the points you are having in your history?
Sir, site of the swelling. Firstly, site TB lymphadenitis is more common in jugular-digastric and supraclavicular lymph nodes. Then secondly, it is gradually increasing in size, and it was associated with fever. It was
just one episode of fever, done for 10 days.
Yes, sir. And sir, then in past history, sir, in the past history, because patient is a defaulter of TB,
That's
it's
the only positive. The patient
Puja.
doesn't have loss of appetite, weight loss, no history of fever, evening rise of fever, no signs of any primary in the lung,
Yes, sir.
symptoms in the lung, right?
Yes, sir.
Puja.
Just lymph nodes.
Puja.
Yes, sir.
Hello.
Hello. Yes, sir.
Hello, it's audible.
Yes, sir.
Sir,
You didn't ask
you're
about
audible,
evening
sir.
rise of fever.
Sir, I did ask for evening rise in fever. Patient had no complaint of it since 4 months. He initially noticed the swelling when he had first episode of fever for 10 days, 4 months ago.
Okay, Dr. Puja, in cervical, tubercular cervical lymph nodes, do you get a typical history of tuberculosis? Clinical features of tuberculosis?
No, sir.
So that was your answer. That should have been your answer. That, okay, I still think of tuberculosis in spite of these things not being there because they're not common in cervical lymph nodes due to tuberculosis. We're waiting for that answer.
Okay, sir.
Right. Okay, let's go to your next slide.
So negative history to
The cervical lymphadenitis is a primary tuberculosis or secondary tuberculosis?
Sir, it is secondary tuberculosis generally.
You understand what is secondary tuberculosis?
So the primary would have been somewhere else, as in if patient would have pulmonary tuberculosis before this, then he can have
Do you think the cervical lymphadenitis is occurring because of pulmonary tuberculosis?
no, sir. It can be because of if patient had spinal TB or if patient has pulmonary tuberculosis.
No, cervical lymphadenitis itself is a primary tuberculosis. Secondary to the lung tuberculosis. If somebody has got a pulmonary tuberculosis, and secondary to that, if some other thing like in the abdomen, abdomen is intestinal tuberculosis. One is ulcerative variety, another is hyperplastic variety. So which one is primary, which one is secondary?
So hyperplastic is secondary.
No, hyperplastic is primary because it is occurring over the Peyer's patches. There is no pulmonary tuberculosis. That is the primary. While ulcerative variety is a secondary variety which is associated with the pulmonary tuberculosis. Similarly, cervical lymphadenitis is also the primary tuberculosis, not the secondary one.
Okay.
What are the various places from where the cervical lymph nodes can come? In the neck? Or you can get the tuberculosis in the neck from what are the various places?
So spine.
Spine, yes.
More common.
Lung.
Tonsils.
hypopharynx.
So you have the Walde's ring, right?
Yes, sir.
Right.
So there are several places from where the lymph nodes can come.
Yes, sir.
Okay, go ahead.
Puja.
Yes, sir.
In secondary neck, in your history should be focused on probable sites of the occult primary. And at the end, you should able to give provisional diagnosis. That's what examiner expect from your in this case.
Okay, sir.
Proceed.
So
which
you
is
must
the
ask for
commonest adenocarcinoma in a female?
Sorry, sir. I did not get you.
Which is the commonest adenocarcinoma in the female?
Endometrial. Endometrial, sir.
Endometrial.
In female.
Endometrial is. Endometrium has got. In the female. adenocarcinoma of the female, which is the commonest one. Every day you see those cases.
Commonest carcinoma in female.
Breast.
Breast, no?
Breast.
That is the commonest adenocarcinoma of the female there. And what is the commonest carcinoma of the females?
We are vaccinating for that.
Cervical.
Cervical.
Yes, cervical, yes, you're right. So the commonest carcinoma in the female is the cervical carcinoma. Yes. Okay.
So should I go ahead with the examination?
Yes, please.
Continue.
In general examination, I have examined my patient in proper light and exposure with consent. Patient was moderately built and nourished with normal temperature, and patient is vitally stable. No pallor, icterus, edema, cyanosis, clubbing, and generalized lymphadenopathy. In local examination, in inspection, approximately 4 into 5 centimeters single swelling was seen over right side of neck in lower aspect, extending from just lateral to lower end of sternocleidomastoid till midline in supraclavicular region, just above medial half of the clavicle. Both the heads of SCM are not visible on the right side. It is a dumbbell-shaped swelling with smooth surface, well-defined margins, no visible pulsation seen. Skin over the swelling is red and edematous with no discharging sinus or fistula on the lateral aspect of the swelling. Swelling does not move with deglutition. No ulcers, scar, dilated veins are seen. Sir, this is the swelling that the patient had. Laterally, sir, here the skin was red and edematous on the lateral aspect of the swelling. On palpation, there is local raise of temperature above the swelling, no tenderness present. A well-defined single swelling of size 4 into 5 into 3 centimeter bilobe located on the right side, just lateral to lower 1/3 of sternocleidomastoid, extending up to midline, above medial half of clavicle. Consistency is firm with soft areas over lateral end of the swelling. Overlying skin erythema over right part of the swelling was present. On palpation, sir, again, multiple smooth lobular surfaces palpated with matted surface, which cannot be separated from each other. Mobile in both horizontal and vertical plane, not pulsatile, does not move with protrusion of the tongue, no impulse on cuffing. It is fixed to the overlying skin, superficial to sternocleidomastoid, and trachea is palpated in midline. No other lymph nodes are palpable in cervical, axillary, and inguinal region.
Pooja, you have mentioned that
Yes, sir.
swelling does not move on protrusion of the tongue. There is need to mention this point here.
Sir, it is a neck swelling, so we would like to.
In all neck swelling, we have to ask this same.
No, sir, midline neck swelling.
And Pooja, you have asked for no impulse on coughing.
That also no.
That's funny. Are you suspecting some hernia there?
Sir, if patient has one of the DD would be either laryngocele of the laryngocele, which has impulse, or secondly, if
What is the site of the laryngocele? Where will get swelling? Upper part, middle part, lower part of the neck?
Middle. Sir, in the upper part majorly.
What is a
Here-
Zenker's
here-
diverticulum?
Yes,
Pooja,
sir.
what is a Zenker's diverticulum?
Sir, it is pharyngeal pouch, Zenker's diverticulum. Sir, it is a protrusion
Between
Between two muscles?
which muscles?
picopharyngeus and stylopharyngeus. Stylopharyngeus muscle.
Okay. So you
What
have
is the
this.
other reason? What is the other reason you were telling?
Sir, the other reason of this swelling, me asking cough on impulse is empyema necessitans if patient, if patient has cuffing and patient has empyema, so there might be an impulse on cuffing on the supraclavicular region in the on the right side.
So communication with thoracic cavity, you mean to say?
Yes, sir. If patient has this cervical lymph node communication in thoracic cavity.
If it would have been abscess.
If it would have been abscess, yes, sir. Cold abscess.
Okay.
Did you examine the cervical spine of this patient?
Yes, sir.
That is normal.
Yes, sir. There was no restriction of neck movements.
Mhm.
And sir, patient had no complaints of any neck rigidity or neck.
Examination. Did you examine spine? Sir is asking.
Yes, sir.
Or should you examine? Okay. How did you examine? How do you examine spine anywhere?
Sir, by palpatory method.
You also inspect, no? Initially.
Yes, sir.
When you examine the lumbosacral spine for a POTS, what do you get?
Wedging of the lumbar vertebra.
What type of the spinal abnormality is there?
Um,
What is that word?
Wedge. POTS.
There's the POTS spine, but what type of the, is it the kyphosis, lordosis, or scoliosis?
It is kyphotic spine. Kyphosis.
It is a localized kyphosis called as the gibbous.
Yes, sir.
Okay, the same thing will be there in the cervical spine also there.
Okay, sir.
Okay. So you have to examine the spine, especially if you're suspecting a patient having the tubercle lymph node in the neck.
Yes, sir.
Did you examine the right upper limb of this patient?
For sir, lymph nodes, for axillary lymph nodes.
Anything
Yes,
else
sir.
in this patient?
If patient has cervical rib or yes, sir. Sir, performing at if patient has cervical rib, so the test for upper limb were performed and they were found to be negative.
Did you really carry out that?
Yes,
Or
sir. No, sir.
you have
Yes,
done
sir.
that?
Yes, sir. I did not mention it in this. I did.
But you are not taking the name of the word which I want to hear.
At sir, name of the test?
No. The syndrome which is there.
Thoracic outlet syndrome, sir.
Yeah, thoracic outlet. So you should mention that name. That suspecting the thoracic outlet syndrome, I examined the right upper limb of this patient. Okay, not for the cervical limb only, for
Okay,
a thoracic outlet syndrome.
Yes.
Did you examine the oral cavity of this patient?
Yes, sir. If there are any,
No, have you examined or not?
yes, sir, I have examined.
Have you given somewhere? Written somewhere? Oral cavity?
Yes, sir. After the palpation in this, sir, oral cavity was normal.
Okay.
Okay, Dr. Pooja, just go back to your slide of your examination. Right. You think this is a tubercular lymph node? Or it's a tubercular abscess?
Sir, it was, sir, it would have been a tubercular lymph node now converting into tubercular abscess because, sir,
So
there
it's
is localized area of
not-
redness.
So tubercular abscess is a cold abscess,
Yes, sir.
but you're getting raised temperature, you're getting change in color, you're getting all signs of inflammation here.
Yes, sir.
So why do you think this is a tubercular abscess then?
Sir, it is developing lymphadenitis, which might be due to tuberculosis or
No, I mean, that's what I'm saying, local rise of temperature.
I think sir is asking you that why tuberculous abscess is called cold abscess.
sir, normally there are no signs of inflammation in cold abscess, like rise of
Yeah.
temperature. or
Why?
redness.
So
Why?
read your slide, no? Read your slide. You're showing signs of inflammation, no? That is
Yes.
what sir is pointing out.
Yes, sir.
So can a cold abscess have signs of inflammation?
Sir,
Can a cold abscess have signs of inflammation? I think that is what sir wanted to ask you.
No, sir. By definition, cold abscess cannot have signs of inflammation. If it is converting into collar stud abscess or developing into a sinus, or if it is bursting onto the skin in further stages of TB lymphadenitis, or so.
So you're
Why
giving
collar stud should give you signs of inflammation? What is the logic behind that? What is collar stud?
Sir,
See,
when
at MS level, I think this is a very good take-home message from all the examiners that you should know what you talk, because what you talk inspires the examiner to ask you further. You
Yes.
follow? So you said collar stud, and now either you become more on thin ice because now you're asked what is collar stud.
Yes, sir.
Because
what-
no examiner comes with a preset questions. Whatever you answer, we will pick up questions from you.
And we come to pass you. Don't make it
Yes.
difficult.
Yes,
So,
yes.
Dr. Pooja, you know what is a collar stud?
To help you.
Tell us, give us the answer. You know what it is. What's a collar stud? You know it. Tell us.
Sir, when sir, the TB when the normal cold abscess, if it crosses deep fascia and comes to the superficial plane, then sir, it becomes a collar stud abscess.
There's a lymph node, deep lymph node, which is turned into which is liquefied into an abscess now, and it ruptures through the fascia, and then some of the pus collects out underneath the skin. So you've
Yes.
got two things joined by a small. That's a collar stud. You know it,
Yes, sir.
right? So now tell us, will you get?
I'm sorry, coming back to the same question that was asked. Cold abscess showing thickness, showing rise of local temperature. Can it happen? Because by definition, according to you, it cannot. Why is tuberculous abscess called a cold abscess? That's a very nice question. And can a cold abscess be like what you are showing in your photograph? It's a developing cold abscess. At periphery, it is firm, and then there is central or eccentric softening. And that softening area, the skin has become red, and there is rise of local temperature. All this is very classical if you know the pathogenesis of tuberculosis of the lymph nodes in the neck. Ultimately, what happens? The pus that is formed finds its way onto the skin. No doctor is required. For years together, there has been tuberculosis. Ultimately, this pus finds its way onto the skin, and you gave your answer, but in a bit of a complicated manner. Ultimately, it will form a sinus.
Sinus, exactly.
And if the defect in the skin is bigger in size, then it will form a tuberculous ulcer. So the moment it forms a sinus, it has found the way pus to come out of the body. And when that pus is closer to the skin, remember this cold abscess now shows you some signs of acute inflammation. But it is still called cold because in a pyogenic abscess, the signs would be present on day 1, day 2. But in a cold abscess, it takes weeks, days, weeks, or a month by the time this pus has progressed from deep plane to the collar stud to the skin. So here you have
And it is present in 4 months.
Here you have a classical case even for other PG students to notice the photograph that a cold abscess can be red.
Yes.
Rise of local temperature.
Is that a good sign? Is that a good sign that there is some sort of inflammation there? What does that tell you?
That sir, body's defense mechanism, the inflammatory.
Right. The person is not immunodeficient.
It is the body's defense system is working,
Very
and
good.
it.
Also, why is tuberculous abscess called a cold abscess? Why are there no signs of inflammation?
So because it lies dormant for years in.
No, that's not the point. Why is it called a cold abscess? Why does tuberculosis not produce a hot abscess? What is the basic cell involved in fighting tuberculosis?
Langhans cells and.
It's lymphocytes. It's lymphocytes. So lymphocytes, they are immune. They are fought by immunity.
Yes, sir.
They fight by immunity. While in pyogenic, you have neutrophils. They fight by secreting anti-inflammatories. You get me?
Yes,
So
sir.
that is
Pooja, what are other causes of
Not
cold
told
abscess?
that what is collar stud?
Sir?
What is collar stud?
okay. Literally in English, what is collar stud? Have you? It's a what is it?
Are you from
It's a
Lucknow? Pooja, are you from Lucknow?
No, sir. I'm from
No, you're
Gujarat.
not. Okay. If you go to Lucknow, you find special dress there.
yes. Lucknowi kurta. Have you worn?
Yes, sir.
Yes. So they wear those kind of studs there.
There are
Not on collar.
that's exactly like that. Okay, so superficial, deep, and then connector is there.
Yes.
You know anything else which is mimicking like a collar stud, where you use in some hernia surgery?
Pooja,
You know Proline hernia system? Have you heard about that? PHS?
They must not have it. They will not
Yes, sir.
come.
Okay, anyway, yeah.
Pooja,
Yes, sir.
what are other causes of cold abscesses other than tuberculosis?
Sir, actinomyces also gives cold abscess.
Okay,
And
gamettic degeneration and
sorry,
nodular leprosy. These are the three causes. Okay.
Okay, now Dr. Pooja, how will you manage this patient? Let's hit this road. How will you manage this patient? These patients come to you in your OPD.
yes, sir.
What do you?
We will, sir, after history and examination, the next step would be investigations in this patient. So, sir, CBC, our routine blood panel, CBC with ESR, if the patient.
No, what do you want to achieve by just to? I mean, why CBC and all? You must have been done so many
How
times
will
for
you
this.
how will you come to conclusion of your diagnosis? Diagnostic tests.
Sir, we can do FNAC in this
Investigation.
patient if the patient is having fluctuation. If we can do, we can aspirate and we can send for CBNAT. Sir, if we are
What
suspecting.
is CBNAT?
In your patient, Pooja,
Yes, sir.
in this case,
Sorry, sir, I did not get the question.
I asked you what is CBNAT. You said you're saying for CBNAT. What's the full form of CBNAT?
Sir, it is a cartridge-based nucleic acid amplification technique.
Very good. So what does it do?
Sir, it detects if there is presence of Mycobacterium tuberculosis and if there is any resistance to rifampicin or
Excellent,
isoniazid.
excellent. Very good, very good, very good. I'm impressed. Very good, good. So,
And sir,
okay.
then. Yes.
Yeah, go on. So you've done it, CBNAT. Have you done it?
Sir, this particular patient was on AKT since 4 months. Sir, the CBNAT was done at the native place of this patient and AKT was started accordingly. This patient was not rifampicin or isoniazid resistant.
So hang on. In your history, did you tell us that all this has been done?
Sir, the patient is taking AKT since 4 months that I have mentioned in the past history.
So in your history also, you must say that this patient has been investigated.
Okay, sir.
I mean,
Your
isn't it?
provisional diagnosis should have been easier.
Yeah,
Or-
we won't.
Yes.
Why go around beating around the bush? Okay. So now what do you do now?
Cervical swelling, like this swelling which is there, you are going to put the needle directly.
No, sir.
Then before that, what you will do?
Sir, if the swelling is just firm, then sir, we can do sputum tests, sputum AFB and
No, coming to the confirmation of the diagnosis. We have to confirm the diagnosis. Are you going to put the needle directly? Or before that, you are going to do something? I say it is a case of a
Sir,
separatism.
sir,
The vesicle malformation is there.
sir, the sonography we will do.
You have to do that.
Always.
Okay.
Yes, sir.
You have to do that. Then only you are going to put the needle.
Yes, sir.
Okay.
Yes, sir.
Particularly when we are discussing
Diagnosis
the
as well as will save you from so many complications,
Yes, sir.
right? So first do the ultrasound, see what it is, and then you go ahead and do the FNAC.
in fact, there is an important finding on ultrasound of this patient. I think, if I am not wrong, Pooja, you can mention it, which is not related to the complication, but there is some complication of this disease. What is that? Dr. Pooja?
Yes, sir.
I think there is jugular venous thrombosis, right?
Yes, sir. In this patient, there
Yes.
was
So
shown.
that also is an important documentation.
Yes, sir.
And why there is thrombosis, jugular venous thrombosis in this patient? Can you correlate these two pathologies?
Sir, then it
If
might
you know,
be,
you can say. Otherwise, don't say I don't know. That will be a good answer.
I don't know, sir.
No, that is no.
Any infection anywhere. Okay, any infection anywhere can lead to the thrombosis of veins.
Yes.
So it is right in that area. And because of that, the patient has got the external jugular vein thrombosis we have seen the internal jugular vein thrombosis. All those can occur because of this.
Yes, sir.
And overall, this patient is an infected case of the tubercular abscess. That is why you're getting the signs of inflammation.
Yes, sir.
Information, yes.
If it is becoming a pyemic jo hai, or it is becoming the pus in that, then there is more chance of having the thrombosis jo hai. So that is the reason in this patient it is the pathology.
Yes, sir.
So what did you get on FNAC in this patient?
Sir, FNAC was showing probability of tuberculous inflammation, and sir, then CBNAT was sent of the patient, and there was no resistance of isoniazid or rifampicin, so the treatment was started accordingly. The 2 months of intensive phase of isoniazid, rifampicin, pyrazinamide, and ethambutol, which was followed by
Was the CBNAT positive in this patient?
What was the question asked, Pooja? You answer what is asked. The questions which are asked, not asked, you do not get credit. But if you are speaking wrong, you will definitely get discredit. Believe me.
Yes, sir.
Was
Give a
CBNAT
pause.
positive?
Yes, sir.
Pooja?
Yes, sir.
Was it positive?
Yes,
CBNAT?
sir. Yes, sir. CBNAT was positive.
And it was not resistant to rifampicin?
Yes, sir.
Okay. Now, what is the tubercular granuloma?
Sir, it is
Granuloma.
sir, it is a collection of cells comprising of epithelioid cells and Langerhans giant cells, which are composed of macrophages with TB bacilli
And
and lymphos. And lymphocytes, sir.
why you are hesitant to say about the lymphocytes? Because those are the majority of the cells.
Majority of cells.
Majority of the cells are the lymphocytes. What is there in the central portion?
Sir, giant cells with
More in the center? Inside the giant cells or inside the Langenbecks?
sir, dead bacilli, dead tubercular bacilli.
What do you call that? What is the difference between a lymph node of the tuberculosis and lymph node of the Crohn's disease? Difference between lymph node of the tuberculosis and lymph node of the Crohn's disease.
Sir, in
Here
TB,
in the center.
yes.
What
Which
is
one
that?
is granulomatous, which is non-granulomatous?
Okay, cageation necrosis is there.
Cageation necrosis.
Okay, in the central part, you will get the cageation necrosis. And that is not there in the case of the Crohn's. Okay.
Yes, sir.
Then what further was done?
So even after starting the AKT, the patient's swelling was increasing in size, and patient presented us with the swelling. So, sir, IND,
IND.
yes, sir.
So
Sir,
do you do IND in case
You
of
can do
tuberculosis?
IND in this case.
sir, because patient presented with gradually increasing swelling and the complaint was the swelling. So, sir, excision.
IND is a treatment of tuberculosis abscess.
No, sir. Uh,
If there is a cold abscess, is there
Better
treatment?
terminology.
sorry, sir.
Which one is a better terminology for this? IND or something, a drainage? Some other kind of drainage. Dependent drainage or non-dependent drainage?
In drainage, sir.
Huh?
Non-dependent drainage of the
Non-dependent drainage is the treatment, not IND.
non-dependent drainage.
Why?
Excuse me, what have you actually done after showing this picture?
Yes,
After showing this picture, a fresh FNSE has been done, or you're telling me the report of the previous FNSE 4 months ago?
Sir, the previous FNAC was there, and after
Forget the previous. अभी क्या किया है आपने?
सर हमने ड्रेनेज करके रिपीट सीबी नैट भेजा पेशेंट का एंड
Drainage मतलब you all have done IND. You have done IND. Infusion and drainage.
Say whatever is done. There is no harm to say, even if it is wrong. Say whatever is done. And what was the finding? Tell us.
sir, incision was kept and the drainage
What was actually planned? What was actually planned?
Sir, actually, it was planned that we will, sir, excision and biopsy we will do of
Yes.
the lymph nodes because
Yes.
it
And
was,
then what it turned out? Tell us.
sir, it turned out to be a cholestate abscess. On operative table, it turned out to be a cholestate abscess. We drained the abscess and we sent the sample for CBNAT post-operatively in this patient.
So the plan was to do a lymph node biopsy. Am I right?
Right. You got to curate out the affected lymph node.
Yes,
If
sir.
you leave it behind, the pus is going to come back all the time. And that's what you've done. You've drained the pus
Yes, sir.
and then you have removed that guilty lymph node.
Yes,
Haven't
sir.
you?
Yes,
That's
sir.
what you do. And you send it for biopsy.
Yes, sir.
If it is resistant, what do you do? If it's resistant to rifampicin
Sir, then
or
I think
amoxicillin,
why she is reluctant is because it is in my unit and it whatever is done, probably she is thinking that the examiner panel is not thinking in that way, but it's fine. Even if something is wrong, it is better to learn from our mistake.
No, sir,
Even
I
as
would
a-
want to, sir, I would want to pitch in here. I have worked
Yes,
in a
yes.
I have worked in a TB hospital.
Yes,
So
madam.
as far as treatment is concerned, drainage is considered appropriate because effect of anti-tubercular treatment improves. And the
Yes,
plan
sir.
of
Yes, madam.
management in this particular case must have been drainage of the abscess and
Yes,
excision
madam.
of the underlying implicating lymph node, which is the cause of cholestate abscess. And
Yes,
so what
madam.
the students must know is that after draining the abscess, the incision in the deep fascia must be incised
Yes,
because the culprit lymph node lies below the deep fascia. So
Yes,
that
madam.
must be removed. And sometimes you may even need to do a selective block dissection in such cases.
Exactly.
So,
Exactly. Actually,
that is-
resident and AP started and I had to join in. I had to find the deeper portion and the cholesterol was drained and even IJV was cleared of the necrotic tissue and it was done the proper excision of whatever
Yes.
necrotic material was there. But I
Yeah,
think
so
she's
what-
afraid that what panel is thinking is aspiration and we have done drainage. Even if
No,
perhaps
yeah.
we have done wrong, there is no harm
No.
in speaking the truth.
No,
Because
this concept stays outside the TB hospitals only, anti-gravity aspiration,
Yes,
because the
there's
effect
nothing.
of anti-tubercular drugs is ineffective
yes,
with
yes,
only
madam. That is
anti-gravity
That
aspiration.
that
in
theory
fact,
about anti-gravity aspiration is out of the window anymore. We
Yeah.
don't do it. We don't consider it. You have to remove the pus. You have to dilate
Yes.
the opening in the deep fascia, remove that lymph node, other lymph nodes which are involved, and start the patient on ATT. The patient gets okay.
in fact, repeat FNEC was also not done. He was straight away posted in OT.
But the previous ultrasound did not pick up that this was a abscess. I mean, you found from the story I'm hearing is that you were diagnostic surprise you got that.
No.
There was-
It was showing lymph nodes and caseation sonography and jugular vein thrombosis was suggesting.
Hmm.
And we knew that because in the central portion there was softening and redness, so there will be some sort amount of pus, but the sonography did not pick up the deeper portion extension and collection, and it was found on table.
Right. So you see the option for the treatment of cold abscess, there is an option of repeated non-gravity aspiration. But in certain
Yes, sir.
cases, as Madam pointed out, that there are cases where patient is not responding to AKT. And one of the reasons is the caseated mass which is there, because that has got no blood supply. The AKT drugs don't.
Yes.
So sometimes you are dealing with a case which is already on AKT and has come with a further disease process
Yes, sir.
just formed into an abscess. So here a more radical approach is advisable.
Justifiable.
So the moral of the story is, Dr. Pooja, you always say what you have done. It is always
Yes,
right. It is always
you will
right.
and you will have to you will not have to twist your story. Even if something is wrong, it is better to accept, I will suggest. Because even if the panel feels that the unit has done something against the principle, it is right to accept and improve next time rather than to twist the story. Do you understand, Pooja?
Yes, sir.
And don't waver. If you've done it, you say I've done it.
Yes.
Yes.
That's it.
See, one more
That is what
thing,
surgeon is. May be wrong decision. It is my decision.
one more thing at MS level. At MS level, there is no pure white and black. There is no pure answer, this or that. You get credit for justifying what you are giving your answer. Because there is always a justification that you can do this because it was
Yes.
like that. And you could
Yes.
do that because it was like that.
Yes, sir.
So at MS level, you should know how to justify what you are saying.
Yes, sir.
Excellent. That's the crux.
Yes.
For
So what-
example, gas under diaphragm. I mean, gas under diaphragm, the standard treatment is what? Expiratory laparotomy, operate
Yes, sir.
for the perforation, say duodenal ulcer perforation. That's a standard. It's the patient is in peritonitis.
Yes,
Now
sir.
you can also give an answer that I will conserve.
Yes, sir.
You can conserve if the patient
Yes.
is not peritonitis. So
You
the
can go wait.
scenario, you are not treating the X-ray showing gas under diaphragm. You're treating the patient.
Exactly.
Patient's abdomen is soft. Bowel sounds are present. Patient is passing flatus. So there are some rare such cases where a perforation has occurred. Momentum has
Let's
set,
see.
has sealed it. What you would do surgically has been done by the nature. So that treatment is known as what? Pooja, MS level? Herman Taylor's line of treatment. Okay. So that is why, see, you justify that, yes, this is also possible if this is the scenario.
Yes, sir.
Now, a primary case of cold abscess, first time coming, not on AKT, nothing like that. And this is the first time you are going to be diagnosing, you are going to be proving tuberculosis, and you are going to be starting AKT, and this patient is going to respond. In that case, why there is justification for this repeated aspiration? Because you're decreasing the morbidity. Patient is going to work every day. If you were to do incision and drainage in that situation, on day one, you have created an ulcer which requires daily dressing. Whereas otherwise, when you're doing repeated aspiration once a week, patient is continuing to work, AKT takes control of the disease, and in 3 months, that cold abscess disappears. What you were aspirating 20 cc keeps on reducing. Ultimately, there's nothing. So you follow, no treatment is to be thrown out of the window. Follow? There is
Yes.
a role for everybody.
Okay, sir.
And one suggestion I'll give you, Pooja, is we should have discussed this in wards. Why not aspiration? Then these things would have automatically discussed in rounds. That, sir, this is the probability. As a PG, you must know that there is a role of repeated aspiration. Why we are not doing it? Even it is our fault, not that we have not discussed because of whatever reason. But this is how it should, and we should treat each and every cold abscess or cervical lymph node like this. We should discuss at least half an hour before planning the treatment. What we do, TBCD reference, pulmonary reference, CBNet, there's that. But we should give due attention to individual case.
Yeah, one more
Though
thing.
because of workload, many times it is not.
See, one more
Yes,
thing
sir.
Madam suggested is lymph node dissection. In tuberculosis, there is a role for lymph node dissection. And in cancer also, there is a role for lymph node dissection. Now, can you tell me the difference of lymph node dissection in a patient who's got cancer versus a patient who's got tuberculosis? I think this is a standard MS level question. Did you understand my
Yes.
question? Lymph node dissection for a cancer patient.
Yes,
Lymph
sir.
node dissection, like for example, your case, you've done something like lymph node excision because that was the offending thing. So I'm partly giving you the answer. Tell me the difference between lymph node dissection for cancer and lymph node dissection for tuberculosis.
Sir, in lymph node dissection for tuberculosis, we are removing the pathology. We are trying to symptomatic relief of the patient. In
Relief in cancer patients, symptomatic relief.
in TB,
want
sir.
pure,
In patients, it is for
No.
diagnostic, the sentinel lymph node and the potential.
No.
No.
You're
You
doing
understand my
it.
question. I'm repeating the question. We have got two patients. One is proved cancer. One is proved tuberculosis. Okay. The one who's proved tuberculosis is on AKT.
Okay.
The one who's cancer is only proved cancer. And in both, in two different operation theaters, the title given to the operation is lymph node dissection, along with the primary cancer. It's obvious, it goes without saying. I'm only focusing on lymph node dissections.
Yes, sir.
What is the difference?
And one more thing I'd like to add what sir is telling. Both have similar group of lymph nodes and almost similar number on imaging. Let us discuss that way now.
Hello, fantastic.
Yes, sir. I got your point.
Something similar to this, right hemicolectomy for tuberculosis, right hemicolectomy for CAC. Keep that aside. But my question is directed something like that. So what is the difference? Tell me. There are those three little sweet words, huh? I don't know.
Yes. Ultimately, it's a correct answer.
बोलो क्या difference है?
Let me specify. Suppose this is a lymph node enlargement of thyroid malignancy. How will you treat this lymph node? And another patient is of tuberculosis. How will you treat this lymph node?
Sir, intraoperatively,
No, planning. You have to plan.
Beta, I'll tell you. Pooja, I'll tell you.
Yes.
For cancer, it is radical.
Yes.
Saman, samjha na? What is radical neck dissection known as? Whose name it is? Classical? Radical neck dissection.
yes, sir.
Iska naam aata hai. There's somebody's name given to it, no? And nowadays we do modified neck dissections. But the classical radical neck dissection. Are you following? So for cancer, you're going to do radical neck dissection. For tuberculosis, you're going to do conservative.
Yes.
Point number one. Point number two. Lymph node dissection in cancer is radical and it is done on the day of treatment itself, along with primary. That is why we do commando operation, no? Some example. Are you following?
Yes,
but
sir.
in tuberculous lymph node, primarily you're not going to remove this lymph nodes. You will start AKT.
Yes.
So the lymph node dissection is done later on when the drugs have not acted.
Yes, sir.
Did you follow? So
Yes.
one lymph node dissection is radical and it is primary with the aim of cure on day 1 of the treatment. But on day 1 for tuberculosis, it is AKT. After 6 months, 4 months, your patient comes. Now, what you have done is a conservative lymph node dissection. And that lymph node dissection is only of the place which is offending. Did you
Yes.
remove the full chain? No, it's not required because the other lymph nodes have come under control. So where the disease, the drugs could not enter because of the caseated mass, you do it. Did you
Yes.
get the answer? So
Yes.
one is medical, second it is done at primary, but tuberculosis is done later on after the AKT and it is conservative.
Yes, sir.
Got it?
I still like to add one thing, sir. In tuberculosis, we will remove the affected nodes, whereas in malignancy, we will remove the all fibrofatty tissue around the vital structures, which we are thinking that they can be involved in that disease.
Exactly, that is
Like
the
IJV,
radical. Yes.
all fibrofatty tissue which are not enlarged, that
Yes.
also we will remove.
Exactly, correct, true. You followed, na? For a CA breast, if you are doing MRM, even if axillary lymph nodes are not enlarged, and if we are doing MRM, we still remove all axillary lymph nodes in a
Yes.
classical operation.
Yes, sir.
And let me tell you that dissection of the neck in case of tuberculosis is much more difficult than the malignant case. Okay, so one should always try to avoid the surgery as far as possible. First, always attempt the aspirations. Give the patient a good amount of anti-tubercular treatment. Still, it is persisting. Think of two things. Either the patient is developing the MDR or there is like a coral stud mass is there that you are going to excise that. But let me tell you in this patient, there is IG thrombosis is there.
Yes.
So when you will go inside the neck here, you will have a lot of the problems there. So before taking up for the surgery, you should be a little careful.
Don't do a lymph node biopsy under local for tuberculosis because you will be suddenly surprised if some vessel gets opened up. You see
Yes.
the disease, it is the capsule of the lymph node has invaded the walls of the blood vessels. Remember that. So every time if you are doing a lymph node biopsy and taking it as excision biopsy, unless it is therapeutic with due investigations, if it is diagnostic, a wedge biopsy will also do rather than you open up internal jugular vein.
Okay, sir.
And no undermining of skin incision. Give adequate incision.
Big surgeons take big incisions, sir.
Yes, sir.
But nowadays the trend has changed.
And has changed.
Yes.
Very
Right.
good case, I suppose.
Great. What are the types of abscesses? Can you define an abscess? Tell me all abscesses that you know after defining an abscess. MS exam है ना? कभी appear हो रहे हो?
Sir, in 1 year.
Oh, 1 year. That's a lot of time.
Yes, sir.
Okay. Tell me. Define abscess.
Sir, swelling which contains pus.
See, definition is definition. समझा ना, beta? It's like mathematics. Either you're right or you're wrong. If I ask you, tell me what you understand by abscess, then you can use your words. What are the types of abscesses that you know? अरे एक तो अभी डिस्कस किया कोल्ड एब्सेस, इसके अलावा और कौन सा एब्सेस होता है?
Sir, based on etiology, sir, it can be.
मांगते हैं वो सब नहीं मांगते हैं. No beating around the bush. खाली enumerate करो 1, 2, 3, whatever you know.
Sir.
Okay, I'll help you. Pyogenic abscess.
Yes.
Okay, one is pyogenic abscess. Second is cold abscess. Third is pyamic abscess. And fourth is antibioma. Okay, which of these four you want to manage? Come, I give you a choice. MS exam, 1 year ahead, huh? We are in 2025 now. Which abscess you want to manage?
Pyogenic.
I'm sure after you have discussed this whole thing, 1 hour you will select cold abscess. I thought you will select cold abscess.
Sir, I wanted to select cold abscess, but it would have been
Very easy, na? So okay, I delete that. I tell you, manage the pyogenic abscess. Batao. How do you manage pyogenic abscess?
sir, because patient is presenting with the
Because
abscess.
कुछ नहीं मांगते, because कुछ नहीं मांगते. Abscess कहाँ पे है? चलो, I give you the choice. You select the site of the abscess. Abscess is on the forearm, abscess is on the arm. Is it an injection abscess on the buttock? Wherever. You must have drained, na? 2 years of residency. Which
Yes.
abscess you have drained? Pyogenic abscess, कौन सा drain किया है?
Sir, gluteal abscess, abscess on.
Gluteal abscess.
Yes, sir.
Was a gluteal abscess or injection abscess? Is there a difference or both mean same?
Sir,
Yep.
injection abscess can be at other side of the body.
Ali, may see, your panel has already advised you that please answer the question. Don't wait anywhere else. Gluteal abscess and injection abscess में कुछ फर्क है कि सेम होता है? तुम्हारा केस क्या था? Gluteal abscess था कि
Gluteal
injection abscess था? Gluteal abscess था,
Yes, sir.
बराबर?
Yes, sir.
But it was not perianal abscess.
No, sir.
It was a gluteal abscess, okay?
Yes, sir.
बताओ, how do you treat a pyogenic abscess? In your case, it was a gluteal abscess. कैसे treat करते हो? How did you treat? Now, don't tell me investigation and everything. What is the treatment of pyogenic abscess?
Incision and drainage.
Very good. How do you do incision and drainage? Is it governed by some rule or law?
Sir, sir, the maximum site of
Okay. Have you heard of Hilton's? Hilton's rule
Hilton's method.
or Hilton's method? ये जवाब देगा तो you are passing MS. नहीं देगा तो how did you pass MBBS? What is Hilton's method? बोलो.
sir,
See,
main
as compared to the gluteal abscess that you have managed, I give you another example of an abscess on the forearm, which is just under the skin. Can you drain that by a different technique? What is Hilton's method? Batao. I hope panel agrees with me that an MS level student should know this, sir.
Definitely, sir.
Yeah.
Definitely.
Batao. Hilton's method of managing a pyogenic abscess.
sir, at the method, sir,
Anesthesia कौन सा दिया? Anesthesia कौन सा दिया? Gluteal abscess को.
sir, spinal.
General. Okay. General anesthesia. Can you drain an abscess under local?
Yes, sir, if the abscess size is small, it can be drained in local as well.
Size is what is important. What is your definition of small abscess according to size? I thought something else was more important.
So
It is not size beta, it is a plane. Is it superficial to deep fascia or the abscess deep to deep fascia?
So superficial. If it is in superficial.
So have you drained any abscess under local?
Sir, breast abscess.
Breast abscess कभी भी local में नहीं करने का, कभी भी नहीं. It's a Chinese torture to the poor patient. Should you remove fibroadenoma under local?
No, sir.
अभी abscess तुम drain कर रहे local में तो fibroadenoma क्यों नहीं? Because breast is a very confusing organ because it is a superficial organ. It is superficial to the deep fascia, but it follows all the rules of a deep organ. Never ever drain a breast abscess or remove the fibroadenoma under local. No, it's always general. तो कौन सा abscess तुमने drain किया है under local? It cannot be breast, and it should not be. Say an abscess which is on forearm, which is superficial to the deep fascia. You can drain under local. So first difference is Hilton's method requires general anesthesia. or as you said, spinal. But other abscess can be drained under local. Second rule about Hilton's method, what type of incision you take? Is it governed by some
Yes, sir.
teaching?
So the underlying structures, nerves and vessels.
So, usko cut kar do.
नहीं sir, उसके parallelly.
So the incision is parallel to the important neurovascular bundle. So did you take incision on gluteal region, which was parallel to the sciatic nerve? I don't know. Hilton's method. Okay, important to the neurovascular bundle. And with what blade you cut after the parts are painted and draped?
Sir, using the stab knife, number 11.
Yeah, 11 number stab knife. So, you understand, you directly go from skin into the abscess cavity and incise it. So in Hilton's method, if it is a deep abscess, your incision should be parallel.
Yeah.
But in a superficial one, it need not be, because there are no important neurovascular bundle superficial to the deep facial. समझा क्या बेटा?
हाँ sir.
Okay, good, great. ठीक है. Hand over to other panelists.
Yeah. So in Hilton's method, she should not go in throughout with the blade. Only the skin should be incised with the blade, and thereafter the sinus forceps or some other blunt forceps should be pushed in, like Sir said, parallel to the neurovascular bundle.
Yes.
There are three. Sorry.
Yeah.
You ma'am, continue. Yeah.
Pooja, do you know what is Hilton's forceps? Hilton's forceps, by which you should do the Hilton's drain. Okay, it is just like an artery forceps, but there is no Reche in that. Artery forceps without Reche. That is the Hilton's forceps. Okay.
So three cases where this pyogenic abscesses are different from the Hilton stitching is, one is the breast abscess, other is a parotid abscess, and third is a perianal abscess.
Correct.
Okay. Now you find the differences and tell me later on, maybe next week,
Okay,
what
sir.
they are.
Okay,
Breast
sir.
ka to answer already mil gaya, because even though the organ is superficial, surgically it is treated as a deep organ.
Yes, sir.
Esteemed faculty, I think we are overshot the time for this case discussion. I request all of you to give the closing comments and move on to the second case to be presented for the day. So since our doubts to be for this case for the last week or so,
So Pooja, good show, huh? Okay.
Thank you, sir.
Pooja, one final question. Can there be a coexisting malignancy and tuberculosis in the cervical node? Okay, that's homework for you. It can coexist. There have been very clear treatment strategies for coexisting tuberculosis in the node. It can be a secondary carcinomatous deposit with tuberculosis in the node, can be lymphoma associated with tuberculosis. Generally, the treatment policy becomes quite challenging because chemotherapy and tuberculosis medicines are not so very friendly to go together. So keep a watch on it. And tuberculosis existing with malignancy is not good for the malignancy, not good for the tuberculosis, right? So it shows there is a gross immunosuppression. You should be prepared. And the treatment strategy for tuberculosis is more extended. And the treatment strategy of the chemotherapy or the degree of intensity of treatment you give for the malignancy also is challenged because of the underlying tuberculosis. All right. So that will be a interesting homework for all the students. I thank Pooja and Professor Hitesh for permitting her to present here. And I'm sure all the students, I think it's been quite some time we had a discussion on TB cervical adenitis. Lot of basics were brought in by the senior faculty here. Students, it is very important. You should go back home today. Make note of all the questions which have been asked, because everything is a gem of a question, like Either it can be your Viva question, it can be your clinical session question in the final MS examination, or it can be your ward round question. See, please go back, read the basics. There is a book called McGregor, there is a book called Kirk. So these are the books, Parkinson's, these are the basic books which will work. And tuberculosis, the JP textbook is one of the best book written by an Indian author with a huge information about various types of progression of nodal tuberculosis, abdominal tuberculosis. I've given the link in the group. I wish all the students take time off to read the chapter specific to surgery at least. Wish you could complete the book. They are so well written about the Indian scenario as well. So wish you go back to read it. Also, tuberculosis existing with parasites. This also will be a common questions asked in the afternoon Viva. You should be prepared to handle it. All right. Good luck to you. And I wish you stay back for the next case discussion. Dr. Arnav, are you with us?
Nice presentation.
Yeah,
Yes, sir.
Yeah, Dr.
One more
Arnav is
comment.
from Raj. Sir, sorry, sir, please, Professor Galani.
I think I would make Pooja and the PG students aware that I have written 2 books in surgery. It's a manual of clinical surgery and instruments and operative surgery. If you had read my chapter on lymph nodes, I've written full chapter on it in which I've discussed tuberculosis in detail. I think you would have been able to answer a lot. Just for your information.
Sir, I request you to give the link in the chat box, sir. The name of the textbook and others. You have a chat box in this. So everybody will get benefited, sir. We have read your books, definitely. So
Can I
wish you
send
could
it to
share
you?
the link.
Sir, can I send it to you on your WhatsApp?
Please send, sir. I will put in the chat box.
Thank you, sir. Thank you. Yeah.
Thank you, sir. Most welcome, sir. So with the permission of the faculty, we move on to the next case. Thank you, Dr. Pooja. Good luck to you. I wish you get back to all the updates which have been advised by the faculty and move on with the more stronger presentations.
Thank you, sir.
Thank you for staying with us till some odd situations at home. Thank you for accepting our request.
Thank you.
And I don't know, please switch on your video. Dr. Pooja, you have to unshare your PowerPoint. Good luck. Thank you. Dr. Arnav?
Yes, sir. Is the screen visible, sir?
Yeah, good to go. But yeah, yes. Good luck to you. Faculty, please take over. Professor Atri, sir, is that you have joined recently, if I'm not mistaken? I could see one senior faculty joining here. Fine. Good luck to you. Faculty, please take over. Arnav, you please introduce yourself, your unit chief and the head of the department, and start your presentation. Good luck to you.
Yes, sir. Thank you, sir. Good evening, faculty. My name is Dr. Arnav Roy. I'm a second-year postgraduate trainee in the Department of General Surgery in Rajendra Institute of Medical Sciences, Ranchi. My unit chief is Dr. Professor Dipendra Kumar Sinha, and my HOD of the department is Dr. Professor Sheetal Malwa. My patient, Mr. X, who is a 37-year-old male resident of Ranchi, factory worker by occupation, belonging to low socioeconomic status. He presented to a surgical OPD with complaint of swellings over both sides of the groin region since 1 year. History of present illness. My patient was apparently well till 1 year ago when he noticed swellings over the groin. It was initially on the right side, and 2 weeks later, he noticed a similar swelling on the left side. The swellings were insidious in onset, gradually progressive. They were initially the size of lemons, and they gradually progressed to the size of a pear. The right-sided swelling is reported to be larger than the left-sided swelling. Both swellings would initially reduce spontaneously on lying down till 4 months ago. Currently, the right-sided swelling reduces by gentle manipulation, whereas the left-sided swelling reduces spontaneously on lying down. On standing or walking, both of the swellings reappear, and they aggravate in size on cuffing or during strenuous activities. There is no history of any period of irreducibility associated with the swellings. The swellings are not associated with any kind of pain, discharge, or skin changes. There is no history of chronic cough, constipation, or difficulty in urination in my patient. No history of fever, nausea, vomiting, non-passage of stool or flatus, or diarrhea were present. There were no other swellings present elsewhere over the body. Past history. There is no history of previous trauma to the perineal region or previous hospitalization of my patient. There is no history suggestive of any previous genital infection. There is no history suggestive of hypertension, diabetes, tuberculosis, COPD, asthma, thyroid disorders, or any connective tissue disorders. There is no surgical history present in my patient. Moving on to personal history and family history. My patient is a married male with 2 children. He is of non-vegetarian diet with normal appetite. My patient has normal bowel and bladder habits with adequate sleep pattern and no history of any allergy or consumption of tobacco or alcohol. There is no history of any chronic drug use in my patient. There is no history of any similar complaint in my patient's family.
Okay.
Shall I move
yeah.
on to the general examination, sir?
Hello,
No,
Arnav.
no, we'll ask you something on history.
Yes,
Sir,
sir.
please.
Arnav, you asked, there is no history of perineal injury or trauma.
Yes, sir.
What is significance to?
Sir, my patient is relatively young, and in case my patient would have suffered any kind of perineal injury, healing of any perineal injury would have been by fibrosis, and obviously it would have led to a formation of a urethral stricture, which would have caused straining during urination, which could have predisposed to
Look,
a hernia.
Arnav, that's carrying the story too far. Perineal injury, urethral stricture, leading to this thing.
This is very remote possibility.
I mean, you just say
Not
that
common
it's
expression, commonly developed.
So either a history of trauma or any kind of
Any other surgery that led to the hernia? Tell me. Commonest thing.
in my patient there was no such history, sir. But
In general, in case of hernia, inguinal hernia, is there any
Yes, sir.
history of operation or which
Yes,
surgery
sir.
led to
Yes,
the
sir.
hernia?
Usually, an open appendectomy may lead to the formation of an.
Okay.
And what about on the left side?
On the left side,
Suppose-
any similar incision similar to the appendix?
Sir, any colorectal surgery such as a diversion colostomy may predispose a patient to the left side.
Okay. By your history, what do you think you're dealing with?
Excuse me, why did you want to ask about appendicectomy?
I'm sorry, sir.
You said appendicectomy, right?
Yes, sir.
Tell me honestly, do you really ask all hernia patients about perineal injury? Tell me, just because you prepared this case, you're putting it up. Have you really asked in your 2 years,
Sir,
3 years of residency?
So in
Shocking.
my particular case, sir, since my patient is relatively young,
No. We see so many young patients with hernia. No, how old is your patient?
37-year-old.
37.
Yes, sir.
How many years of resident you have been?
So this is my second year, sir.
So really, after 1 year of inguinal hernias, you've asked everybody about perineal injury?
No, sir, not.
Honestly asking you.
No,
Honest.
sir.
Okay, forget
sir.
it. Appendicectomy, you said.
Yes, sir.
Why you are specifying on appendicectomy? Appendicectomy can produce hernia, inguinal hernia?
Sir, currently no, sir, because we use a muscle splitting incision.
Oh, in the olden days,
So previously,
in the olden days, what we people used to do? We are all old people. So we were producing all hernias. There was no laparoscopy at that time. How appendicectomy can produce? Which side inguinal hernia it will produce appendicectomy done?
Sir, it will produce a right-sided inguinal hernia.
How? Tell me the mechanics. How does that happen?
Oh.
MS level, I want to know what happened in that appendicectomy operation that the patient developed with right inguinal hernia. How is it possible? Tell me.
So in case during an appendectomy, there's damage to the ilioinguinal nerve, sir. It may lead to decreased strength in the musculature of the abdominal wall.
Which muscles? Which muscles?
He can't be
Say-
beating around the bush. Ilioinguinal nerve damaged in McBurney's appendectomy, correct?
Yes, sir.
And in an open inguinal hernia also, many times we see ilioinguinal nerve and we damage it.
Yes, sir.
So damage at the inguinal hernia operation and the damage at the appendectomy operation, same nerve is getting damaged.
Yes, sir.
So why should it produce hernia?
So because the motor fibers are present at the level of at which we're giving the McBurney's incision, whereas in
Very
the
good, very
inguinal
good, Beka. Very good, very good.
Okay, which muscles?
Very good, correct
Which
answer.
muscles?
But
so
now,
internal oblique and the transversus abdominis, sir.
no, no, no.
Right.
Yeah, but that combo is called what? As far as hernia is concerned.
So the conjoint tendon, sir.
Very
Yeah,
good.
correct, correct. Understood. Now, when the inguinal hernia gets damaged in an open inguinal hernia operation, then what is the damage leading to?
It's only leading to sensory damage to the sensory supply.
Very good, very good.
So
Good.
where is the sensation lost?
So mainly over the root of the penis and the lateral part of the scrotum, sir, as well as the medial part of the thigh, sir.
Very good. Good. Okay. So you've taken the history. What is your provisional diagnosis?
So based on my history, my provisional diagnosis would be a bilateral inguinal hernia, sir.
Okay. Let's go back to your history. Let's start off with your history.
Yes,
First slide. Why do you think it's an inguinal hernia?
This patient complains of swelling over both sides of his groin, sir. In this particular case, sir, he's complaining of two specific swellings, which are both pear-shaped.
No, hold on. Enough. What is so specific? You said the swelling is in the inguinal region. One.
Yes, sir.
What is so specific in your history which you tell it's a hernia?
So that it reduces on lying down and it reappears on while doing strenuous activities, sir.
So just say that.
Yes, sir.
Just say that. That's right. So you think it's an inguinal hernia?
Yes, sir.
Is there any cause for that hernia? Any precipitating factor for that hernia?
Yes, sir. The patient, while coughing or while doing any strenuous activities, the hernia does aggravate in size, sir.
Okay. Any underlying factor for that hernia to happen?
No, sir. There's no history suggestive of.
Right. So what are the underlying factors? You said history of
So there's no history of chronic cough, constipation, or any difficulty in urination.
Yeah, next slide. You said something about connective tissue disorders.
Connective
What do you
tissue
think that
disorders.
history?
Yes, sir.
How do you take that history?
So we asked the patient about any increased laxity of the joints or increased laxity of the skin, sir, or hypermobility of the joints, sir.
What are you trying to figure out?
If there is an underlying collagen disorder, sir.
Lead to?
Sir, if there's
Collagen
a
disorder is a precipitating factor for hernia? Inguinal hernia?
yes, sir, if an underlying collagen disorder is present, it might lead to presentation of a hernia, sir.
Okay. Should we move to the examinations? Yeah, go on.
So, may I move to the examination, sir?
Yeah, please.
The general examination of my patient was done after taking due consent in a well-lit room. My patient was alert, conscious, and cooperative, well-oriented to time, place, and person. He's of average build with BMI of 20 kilograms per meter square. He's well hydrated. There are no signs of pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema present. My patient is able to stand straight with erect posture. The blood
What
pressure
is this able to stand straight with erect posture? You think it would be on 4 legs otherwise?
No, sir. I'm just again ruling out any.
Any what?
In my history, I did take a negative history of connective tissue disorders. I'm just ruling out if there's.
So a patient of connective tissue disorder will not be able to stand straight with erect posture. He'll be on his fours.
Not necessarily.
I mean, don't try to put unnecessary stuff to make it flowery.
Yes, sir.
Just see the trouble.
Yes, sir.
Also, radiofemoral delay. What is no radio? When do you get radial delay and radiofemoral delay?
Sir, in case of thoracic outlet syndrome, sir, we might get a radial delay.
In thoracic outlet syndrome, you get radial or radiofemoral delay.
Radial delay, sir.
Okay, so radiofemoral, when do you get?
So it might be in a case of aortic aneurysm, sir.
Aortic aneurysm. You're wrong both ways, so you lose marks. Do you ever do radiofemoral delay or radial delay in a case of hernia?
Not routinely, sir.
Also, otherwise in the exam you do it.
No, sir.
Then you don't know about it and you're putting it. If you're putting it, go and read about it. Because you want to get questions on them.
Yes.
Do you get me?
Yes, sir.
Yeah, go on.
The pulse rate of my patient is 84 beats per minute, paired in volume, regular in rhythm. The respiratory rate of my patient is 14 per minute, which is abdominal thoracic. Saturation of my patient is 100% lumen. Local examination of the bilateral inguinal region was done. Patient is exposed from nipple to mid-thigh. The inspection was done in standing position. Two swellings are appreciated, one on either groin region. The right swelling appears to be slightly larger than the left-sided swelling. On the right side, there's a single swelling, which is piriform in shape, extends approximately 2 centimeters above and 3 centimeters lateral to the pubic tubercle, up to the base of the scrotum. The length is approximately 15 centimeters on the longitudinal axis.
On inspection, how do you know where the pubic tubercle is? On inspection, can you see the pubic tubercle?
Sir, in my case, I was just able to appreciate this. Otherwise, a better.
No, you cannot. In your case, also, you cannot. Don't make it an exception. You can't see pubic tubercle, please.
Sir, then I would like to.
Yeah, show us the picture.
Like to measure from the pubic symphysis, sir.
What is the fun of measuring it? Does it help in your diagnosis?
No, sir.
Does it give you any clue on your surgery?
No, sir.
Then what's the fun of it? No one does it. Look, Arnav,
Yes,
Arnav is Arnav. Do what you do in your hospital. Examination is nothing different from what you do in your hospital. Don't try to put in this flowery stuff to make it sound very esoteric. You don't. You make a fool of yourself. Go on.
Yes, sir. The surface of the swelling is smooth. The margin appears to be well defined. The skin over the swelling is normal. Cuff impulse could be appreciated on inspection. There is no scar, pigmentation, or venous engorgement. No visible peristalsis or pulsations could be appreciated on inspection. On the left side as well, there is a single swelling, which is piriform in shape. It is about 8 into 5 centimeters on longitudinal and transverse axis. The surface is again smooth. The margin appears to be well defined. Skin over the swelling is normal. Cuff impulse could be appreciated. No scar, pigmentation, or venous engorgement is present, and no visible peristalsis or pulsations.
You found cuff impulse on this patient on standing position.
Yes, sir.
You found cuff impulse in this patient, what is this kind of a scrotum called? What's an abdominal scrotum? What is an abdominal scrotum? Do you have an idea what is an abdominal scrotum?
No, sir.
When the whole majority of the gut is in the scrotum.
Yes, sir.
It's there in a picture. So you can't appreciate cuff impulse there, please. You can hardly. The whole thing is jammed.
Dr. Sahai, I want to interrupt. I want to interrupt because I want him to go back to the previous slide where he's talking about pubic tubercle.
Yes, ma'am.
Yeah. So you have written that 3 centimeters lateral to the pubic tubercle. What do you interpret from this? What kind of a hernia are you dealing with?
Ma'am, I interpret that this might be an indirect inguinal hernia, ma'am.
Do you think an inguinal hernia is present lateral to the pubic tubercle? It's a very gross mistake, you should read and correct yourself, because femoral hernias are present lateral to the pubic tubercle and inguinal hernias are present superior and medial to the pubic tubercle. Okay?
Yes, ma'am.
This is a gross mistake which
Yes,
you
ma'am.
should not make.
Yes, ma'am.
Please proceed. Please proceed.
On palpation bilaterally, the temperature over the swellings were not raised and tenderness is not present. Findings found on inspection were confirmed on palpation. The right swelling extends up to the base of the scrotum, whereas the left swelling extends up to the superior pole of the testis. The consistency is of both the swellings is elastic bilaterally. The testis could be palpated separate from the swelling, and it was not possible to get above the swelling bilaterally. A tympanic note could be found over both of the swellings on percussion. On auscultations, normal bowel sounds could be heard bilaterally. The patient is then asked to lie supine. The left-sided swelling reduces spontaneously, whereas the right-sided swelling persists. The patient is then asked to reduce the swelling himself gently. The swelling is reduced completely and comfortably with a gurgling sound, with slight difficulty in the initial part. The patient is asked to then cough. Both the swellings reappear with a cough impulse. The swellings are reduced again, and a deepening occlusion test is done in the standing position. Bilaterally, cough impulse was felt on the palp of the thumb, with no swellings appearing medial to the thumb placement. So this is a picture of the hernia on the lying position. For
You had a
abdomen
different
exam,
picture in the initial in the beginning. Was the picture different in the beginning?
yes, sir. That was in the standing position, sir. Let me just, yes, sir.
Yeah, here the thing looks much larger. Anyway, yeah, go on.
One thing, Mr. Arnav,
Yes, sir.
this when you are reducing a inguinal hernia, you ask the patient to reduce?
Sir, we may reduce it during examination as well, sir, but it is the
But
patient is more.
No, who gets the marks in the exam? You or the patient?
Sir, I do, sir.
So
Sir, I
yours-
would reduce the swelling, sir, but I would do it.
How do you reduce?
Sir, I would reduce the swelling by first asking the patient to lie down in supine position, then asking him to flex his hip and knee joint, and then turn his knee joint slightly medially.
What is this procedure called as? There is a name given to this.
So this procedure is known as taxis.
Taxis. So how much of flexion? How much of blah, blah, blah? And where are your hands? You have to
Sir,
exactly demonstrate. In the MS exam, you'll be asked to demonstrate.
yes, sir.
So tell me.
Sir, the patient is
Right
asked.
Right inguinal hernia, you are now demonstrating reduction by the method of taxis.
Yes,
so
sir.
do it correctly, verbally. Tell me.
Yes, sir. So patient is asked to flex the hip joint to about 45 degrees and the knee joint to about 45 degrees, and then slightly internally rotate his knee joint.
45 degrees. कौन सा book में दिया है?
45 degree.
Which book gives you
Where
40?
it is given?
Or you have made it yourself?
I'm sorry, sir, I'm just estimating, sir.
ऐसा estimate नहीं होता है ना बेटा एग्जाम में. एग्जाम में estimation तो एग्जामिनर भी मार्क्स एस्टिमेटेड देगा. You have to be perfect, ना? See, clinical science में you cannot be deficient. Theory में थोड़ा बहुत हो सकता है. If you are asked to demonstrate, the flexion of the hip is 30 degrees. I'm telling you.
Yes, sir.
Next क्या होता है? After flexion of the hip.
The flexion of the knee is done, sir.
That is immaterial because ultimately he is supposed to rest on the bed, couch.
Yes, sir. Yes, sir.
So hip का
And the
बताओ.
patient
Hip का
and the-
flexion is 30 degrees. और क्या
Yes,
होता है?
or internal rotation of the hip joint, sir.
कितना?
15
All
degrees, sir.
thing depends upon that, beta.
Sir,
How much
15 degrees.
internal rotation?
Okay, why do you have to do this maneuver?
बताओ. Fantastic, sir. Fantastic
So
question.
this maneuver is done to relax the superficial ring, sir, so that the contents could be more easily reduced.
To relax superficial ring or to relax abdominal wall muscle? Which
So
one is
abdominal
correct?
wall, both abdominal wall muscles, sir.
तो मूवमेंट्स क्या है? फ्लेक्शन, दूसरा क्या बोला? व्हाट
So
डिड यू
flexion,
उसके
so flexion of the knee joint, the flexion of the hip joint, and the internal rotation of the
खाली हिप
hip.
जॉइंट का बात करो, खाली हिप
Yes,
जॉइंट की बात करो। फ्लेक्शन,
Flexion.
इंटरनल रोटेशन,
Yes,
और
sir.
दूसरा भी आता है। थर्ड थिंग इज आल्सो रिक्वायर्ड एट द हिप जॉइंट। ये ऐसा नहीं करेगा तो बेटा एग्जाम में फेल होएगा, एटलीस्ट ऑन डेमोन्स्ट्रेशन ऑफ दिस साइन। एडक्शन,
Adduction or
Adduction, sir.
adduction?
okay, flexion, internal rotation and
And
adduction,
adduction, sir.
30 degrees, 10 degrees, 10 degrees.
Yes, sir.
In some other books it is given as 30 degrees, 15 degrees, 15 degrees.
Yes, sir.
You follow any one of these two, you are right. You make up a third combo, you and I, we are all wrong. Okay,
Yes, sir. Yes, sir.
proceed then. And so that is one thing. Then just show that slide. Some other thing occurred. वो एग्जामिनेशन में क्या बोल रहा था? इसके पहले का स्लाइड क्या बोला? हाँ, what did you say?
No.
Yes, sir.
Percussion, percussion.
What are the complications of taxis? What complication can it?
Sir, a forceful taxis can reduce the swelling with the constriction ring in case of an irreducible hernia, sir.
Lead to? Repeat again, sorry.
So forceful taxis, sir, might reduce the hernia content with the constriction ring, sir.
So that is called as?
Reduction in mass, sir.
Okay. Any other? Any other complication?
Sir, it might, if suppose it is if it is a strangulated hernia, sir, it might lead to, sir, reduction of the toxic fluid in the strangulated hernia and back into the peritoneal cavity, sir.
Really bowel injury. Okay.
Yes, sir.
अच्छा, वन अदर थिंग बेटा, डीप रिंग ऑक्लूजन टेस्ट तुमने बोला, किधर तो लिखा है तुमने? कहाँ पे?
Yes, sir. Next, sir.
डीप रिंग ऑक्लूजन टेस्ट कहाँ पे लिखा है? हाँ, डीप रिंग ऑक्लूजन टेस्ट डन इन स्टैंडिंग पोजीशन।
Big position.
ये कैसा होता है? स्टैंडिंग पोजीशन में डीप रिंग ऑक्लू किया?
Sir, no, sir.
स्टैंडिंग
In the supine position, after the swellings were reduced, the deep ring the deep ring was palpated, and after that the patient was asked to stand, sir. But in some books, it is written that the deep occlusion test can be done in supine position as well, sir.
No, it is always to be done in supine. Standing में करता है क्या कोई? Deep ring occlusion test is followed after taxis.
Yes, sir.
Taxis में supine होता है क्या standing होता है?
So taxis में supine होता है, sir.
So deep ring occlusion is also in supine, ना?
Yes, sir.
तो standing में क्यों लिखा है? Deep ring occlusion test done in standing position. तुम्हारा ही slide पढ़ रहा हूँ मैं.
Yes, sir. Sir, in some of the literature, sir, it is written as
क्या बात करता है? Literature बोलता है? वो book पढ़ने का छोड़ दो. No literature will give you deep ring occlusion test is to be done in standing position.
Okay.
Standing में तो swelling बाहर है ना बेटा?
Yes, sir.
What are the fallacies of deep ring occlusion test?
So fallacies of a deep ring occlusion test, sir. In case of the deep ring is wide, sir, it might still sir.
Okay. Other causes?
So if there's an accompanying direct hernia in case of a pantaloons hernia, sir. In case of a pantaloons hernia.
What is the anatomical location of the deep inguinal ring? How will you locate it?
So first we will palpate the pubic tubercle and the anterior superior iliac spine, sir, and we will join a line connecting these 2 points, sir. Then we will find the midpoint of that line and go 2 centimeters superiorly, sir.
Midpoint. Midpoint of inguinal ligament or mid-inguinal point?
So midpoint of inguinal ligament, sir.
Oh, no.
What is the difference between these two? Mid-inguinal point and midpoint of inguinal ligament?
The midpoint of inguinal ligament is the midpoint between the ASIS and the pubic tubercle, whereas mid-inguinal point is the midpoint between the ASIS and the pubic symphysis.
So the other one is more important.
Points. So deep inguinal ring is at which point?
So it is at the mid-inguinal points.
Not midpoint of inguinal ligament, no?
No, sir.
Which one is correct?
Mid-inguinal points.
And femoral vessels?
The femoral vessels are, would be at the level of at the midpoint of inguinal ligament, sir.
Oh.
No, no, no. Are you making mistakes? One of the easier methods is palpate the femoral pulse and go half an inch above that. It is mid-inguinal point for both.
Sir.
Okay.
Okay, complete your examination, please.
Yes, sir. For abdominal examination, on inspection, the abdomen is neither scaphoid nor distended. The umbilicus is centrally placed and inverted. The umbilicus is centrally placed and inverted. All quadrants are moving equally with the respiration. There is no scar, pigmentation, venous prominence.
Abdomen is normal, huh? Abdomen
Yes,
is
sir.
normal.
Abdomen is normal.
So,
Examination, inspection, palpation, percussion, and auscultation of the abdomen is normal. Examination of the external genitalia is also normal. The prepuce was able to retract with the glands easily, and the glands is normal, sir. Consent was taken before per-rectal examination. Examination of the perineum and the per-rectal examination is also normal. The examination of the respiratory system, CVS, CNS, and the musculoskeletal system is also normal, sir.
you did per rectal examination actually, or you're writing it up for the exams sake?
No, sir. I did per-rectal examination.
Yeah, in a 37-year-old male patient. Why?
So just to rule out any.
What do you want to rule out? Tell me.
So I just to rule out any bladder outlet obstruction due to prostate hypertrophy, sir.
वही बोल रहा हूँ 37-year-old patient है.
So it is, yes, sir.
Who has got no symptoms, no urinary symptom.
No urinary symptoms, sir. Yes.
Yeah. Okay. ठीक है. You did it. All right. Normal?
Yes,
Or
sir. Normal, sir.
prostate?
Normal, sir. Normal, sir.
Arnav, I would also like you to examine the penile urethra, which you've.
Yes, sir.
So you should mention it if you've done it.
That is more important.
Right?
Yes, sir.
And you must mention the external meatus also, whether it's normal.
Yes, sir. Sorry, sir.
And of course, the testes, you should palpate them and say that they're normal.
Yes, sir.
So what's your diagnosis now?
So my somebody is a 37-year-old man presenting with a bilateral reducible inguinal swelling, which is right side is more than the left. Cuff impulse was present. Testes were palpable separately from the swelling. It was not possible to get above the swelling, and
I
they
think
reduced
you
with
were
gurgling
asking
sound.
diagnosis. Give your diagnosis. Not
So
the
my
symptom.
provisional diagnosis is a bilateral reducible indirect inguinal hernia, which is complete on the right side and incomplete on the left side, without any complications, probably with enterocele as content.
How do you know it is enterocele?
So the swellings reduced with gurgling sound.
You never reduced it. Your patient reduced it.
So
By your
even
note.
even
As per your notes, your patient has reduced it. So you ask the patient whether he felt gurgling.
no, sir, even on reduction by myself as well as during reduction by the patient, gurgling sound could be heard, sir.
When patient reduced, you could hear gurgling sound.
Yes,
How
on the right side, sir, it was a
Tell me, my God, you must be having fantastic ears. Patient is reducing the hernia and you are able to hear the gurgling without stethoscope.
So on reduction of the swellings by myself as well, the gurgling sound could be heard, sir.
तुम reduce किया तो I can agree that you heard the gurgling.
Yes.
Right. So you think it is enterocele on the right side?
Both sides, sir. I think it is enterocele on both sides.
Oh, acha, both the sides enterocele. Acha. Okay. Complicated.
Okay. How will you manage the patient now?
What will you do?
Sir, hernia is a clinical diagnosis, sir, but I would like to do an ultrasound.
God, oh my God, don't tell me. For an inguinal hernia, you need ultrasound.
Also, why do you want to do an ultrasound?
Sir, to rule check the other systems as well, sir.
What system are you going to check
abdominal,
up?
just to
Oh my God. For diagnosis
So
of
for
hernia,
so for to rule out ascites or any organomegaly that might have been missed on clinical examinations.
So you want to
But not-
confirm what you missed. You want to confirm what you missed. Look, you yourself said it's a
clinical
clinical
diagnosis.
diagnosis.
Yes.
So that's it. Why are you trying to strike down your own statement? You will get
So
an
then I would-
ultrasound done
Yes, sir.
if the patient has any other symptoms like bladder outlet obstruction or something suppose got a vesical calculus or something. If he's got symptoms, otherwise you get an ultrasound of all the patients who come with inguinal hernia to you. You don't,
No, sir.
unless you suspect something, right?
Yes, sir. So then
So what can you do now?
I would proceed with the treatment, sir.
Oh, one thing.
Oh, straight away.
One
Straight
thing.
away.
I'll interrupt you. Sorry, sir. 1 second. You did not
So,
tell me about the muscle tone. तुम्हारा diagnosis में I was going through. Muscle tone is what?
So muscle tone of my is normal, sir.
So
how
लिखा
do you
तो
test it?
you have
So,
not written it.
so during per abdominal examination, sir, the patient was on inspection. The patient was asked to flex his flex his neck, and no bulges could be found, sir.
What are those bulges found and where do you find them?
So they're known as Malgagny's bulges, sir.
And where do you find them?
So they're found on either of the flank regions.
Okay, so what does that tell you?
It
Suppose they're not present.
sir, it indicates a decreased muscle tone of the abdominal muscle.
So does it change your treatment?
No, sir, it does not change in my treatment, sir.
It used to change the treatment previously when we are not using meshes.
Yes, sir.
Okay, now what will you do? Proceed.
So I would go ahead with the with telling the patient that he needs surgery.
Okay, you'll counsel the patient for
Yes, sir.
surgery.
Yes, sir.
So why do you want? He says I don't want surgery. Convince him that he says I don't want surgery.
So if the patient says he doesn't want surgery, I would explain to him that in a hernia might get complicated at any moment. It could be 1 day from now or 6 months from now. And if it gets complicated at that event, sir, he would have to rush towards the emergency. And
What
at that time,
What complicated?
so in case the hernia becomes obstructed or strangulated, sir.
So you'll tell him that if hernia gets obstructed or strangulated, how much is he educated?
So I would tell him that his so I would explain to him that his bowel could get caught inside the hernia and might not be able to come back.
Right. So you'll tell him that there can be a problem with his bowel, and he might require an emergency
surgery. And the
What is
outcomes
the-
of
what
that.
is-
Yes, sir.
What is the difference between irreducible hernia, obstructed hernia, and strangulated hernia?
In an irreducible hernia, sir, is one in which reduction is not possible, but the normal peristalsis of the bowel occurs without any obstruction, and normal blood flow to the gut is maintained, sir. In case of obstruction, sir, it is obstruction is mainly extraluminal, sir, and it causes non-passage of the stool or
Okay, go on.
non-passage of stool and flatus, sir. And in case of strangulation, sir, there is a compromise to the blood flow to the gut, sir.
So if there is intraluminal obstruction, what is that called?
So it is so it is intestinal obstruction, sir.
Is there a special term for it in hernia? You said no, that obstruction is usually extraluminal.
Yes, sir.
So it's intraluminal. What is it called?
So it is if it is intraluminal, it's known as an incarcerated hernia, sir.
So right. So this incarceration, that's the fecal matter.
Due to hard fecal pellets, sir.
Very good.
Then what is inflamed hernia?
So inflamed hernia is a hernia in which the contents are inflamed. It could be due to any cause. it could be due to an inflamed appendix or an inflamed Meckel's within the hernial
Which
sac. Sir.
content is appendix is called as? Hernia is called as?
If the content is appendix, sir, it is known as Madel's hernia, sir. If the content is
Maidels.
Repeat.
Oh, no.
It's Maidels. What is Maidels?
I'm sorry, sir. If the, Madel's hernia is, sir, in which two loops of the
Okay.
gut.
So appendix is? Okay, it's aminoids. Okay.
Am I right? Sorry, sir.
Right. You said it's an indirect inguinal hernia,
Yes, sir.
right? So what's the difference between a congenital inguinal hernia and in this patient's hernia? Why don't you call it a congenital hernia? There also you got a sac. Here also got a sac coming out.
Sir, it could in my patient's case it could be a congenital indirect inguinal hernia, sir.
So why don't you call it a congenital hernia? Do you ever call this a
Congenital
congenital hernia?
hernia?
So most indirect inguinal hernias are due to a patent processes vaginalis.
So
And
why don't you call it a congenital hernia?
I can, sir.
You can? You can?
No, sir,
But do you?
because no, sir, since this hernia does not present since the birth, I would refrain from.
So you get in a child also, they present with a hernia after 2 years of age, suppose 3 years of age, we call it congenital hernia. But at this, we are not calling it a congenital hernia. So this,
Not sure, sir.
what happens is that there's a potential space. In an adult, it is because of the weakness of the muscle. In child, there's no weakness of the muscle.
Yes, sir.
Here, there is some weakness in the muscle, and this potential space is there, and the hernia happens. So the basic pathology is there's some problem in the shutter mechanism, in the mechanism of the inguinal canal
Inguinal
in
canal,
adults.
sir. Yes, sir.
In adults, there is a Russell-Hamilton theory which says all hernias are congenital, which is right. Indirect hernias have this congenital sac. So there's a potentiality. But in children, it has nothing to do with. That's why you just do a hernia. You don't have to do any repair.
Yes,
You
sir.
get me?
Yes, sir.
What is a Litter's hernia? Since we were talking about contents.
So Litter's hernia is if the content is a Meckel's diverticulum, sir.
Now, who came first, Litter or Meckel's? सोचा है कभी? हाँ? The nice
Richard's hernia.
in daily love.
What is Richard's hernia?
Not sure.
Okay, most important. How many different? What is the differential here now?
So my differential diagnosis could be, sir, a direct inguinal hernia, sir. It could be a large hydrocele, sir.
Oh my God.
Okay, you said it direct inguinal hernia. Can it be a Pentalus hernia? You can't go and can't give differentials like that. Your first differential would be a
Sir,
femoral hernia,
yes, sir, a femoral hernia, sir.
right?
Yes, sir.
Then you get to all those, whatever you want to say. So how will you differentiate between the two? A femoral and a inguinal?
So first is the shape, sir. The shape would be of an indirect inguinal hernia, sir, is pyriform in shape, sir. Whereas the femoral hernia is usually retort in shapes, sir. Second, sir, we can do Siemens three-finger test, sir.
What is the Siemens three-finger test to distinguish it from a femoral hernia?
Sir, in the Siemens three-finger test, sir, if the calf impulse is felt over the ring finger, sir, it would indicate a femoral hernia, sir. Whereas,
Where does a femoral hernia happen?
Sir, below and laterally to the pubic tubercle, sir.
Right. So the best, that's that. If the femoral canal is there, so get
Yes,
a femoral hernia. Okay.
Yes, sir.
So he says, okay, surgery. What surgery will you do for this guy?
Sir, so patient is a candidate for laparoscopic repair of both hernias
So,
in a single setting.
have you done any laparoscopic hernia repair?
I've assisted in bilateral E-TEPs.
So the patients come to you in your clinic and he says, I want a laparoscopic hernia repair. You suggested, he said, okay, fine. Now what do? You tell him I've just assisted, I'll not be able to do it.
No, sir, I would try to organize a team so that we can do, if the patient wants a laparoscopic repair, sir,
Exactly. You'll call for help. You'll ask someone.
I'll call for
to help
somebody
you.
to help me.
Very
in that
good.
situation, sir.
Okay, so what laparoscopic hernia will you do here? Repair.
So in this case, I would like to do a bilateral E-TEP procedure, sir.
What is E-TEP?
So it is enhanced view total extraperitoneal repairs.
Okay, how does it differ from a conventional TEP?
So in a conventional TEP, sir, all the ports are lying in the midline below the umbilicus, whereas in a E-TEP, sir, the camera port is slightly above and lateral, so that we have a better view.
Is that so? Is that so? What does E stand for?
So extended or enhanced, sir.
Yeah, so extended. Well, what does extension mean?
Extension means, sir, we are able to tackle all the myopectoral orifice, sir.
You can do it with the normal. Here we are covering the umbilical port of the hernia also.
Yes, sir.
That is the difference. With
Yes.
myopectoral, I'm going to cover the umbilicus also.
Oh, yes, sir.
That is E-TEP.
Yes.
So why do you want to do E-TEP for this guy?
So, if the patient wants a laparoscopic repair, sir,
Okay. What is the difference between Liechtenstein and laparoscopic repair? Basic difference.
so in Liechtenstein,
Principally.
it is an anterior. Sir?
Principally, what is the difference?
So Liechtenstein is only combating the direct and the indirect inguinal hernias, sir, whereas an E-TEP procedure would combat both the inguinal hernias as well as a femoral and an obturator hernia, sir.
So you're covering with a laparoscopy. I'm covering the myopectoral orifice.
Sir.
So what is the myopectoral orifice?
So the myopectoral orifice extends anterior and posterior to the inguinal ligament, sir. Anteriorly, it is bounded by the iliopsoas and the cruciate ligaments, sir, as well, and posteriorly, sir.
What do you say?
So the anteriorly it is bound by the iliopsoas, sir. I'm sorry, posteriorly it is bound by the iliopsoas, sir, and as well as the lacunar ligament, sir.
Anteriorly, is there something anteriorly or is it superiorly? What have you got in anterior portion of the myopectoral orifice? There's nothing called anterior posterior.
Sir,
superior, inferior, medial, lateral.
Sir.
Go and read about it. I can't teach you here.
Sir.
So go on, please. Okay. Have you, what are the complications of Liechtenstein's hernia?
Complications of Liechtenstein's hernia would be, sir, first is injury to the ilioinguinal nerve, sir.
That's a very common complication.
Most complication, sir.
It's the most common complication.
Yes, sir.
Okay. That means you don't know your anatomy if you're doing it. If you're injuring the ilioinguinal nerve every time you do the surgery, that means you don't know the anatomy. What is the most common complication? The hospital में देखा है inguinal hernia repair?
Yes, sir.
सब में inguinal nerve कट जाते थे majority में.
नहीं सर, सब में नहीं करता सर.
Majority में कट जाते हैं. Most commonly वही करते हैं. तब क्या देखा सबसे common complication वहाँ पे?
Sir,
when you're putting a foreign body, you're putting a mesh.
Yes,
what
sir,
are you most afraid of?
So for a formation of a seroma, sir.
Seroma,
Or-
yeah, sir. Just because
Or
someone
infection, sir.
said-
Infection, sir. Infection. Sir.
Infection.
Yes, sir.
Right. That is the most common.
Yes, sir.
Then
Sir, after that, sir, injury to the inguinal nerves or the iliohypogastric nerves, sir.
yeah, let go of these nerves here, please.
Sir,
What are common complication? Okay, how do you know that these nerves are damaged? And what happens?
Sir, in case the ilioinguinal nerve is damaged, sir, we would lose sensation over the.
So what? So what?
So there is a burning sensation immediately post surgery that would indicate damage to the ilioinguinal or the iliohypogastric nerve, sir.
What are the types of nerve injury?
Sir?
What are the types of nerve injury?
Sir, a nerve injury could be, sir, a neuropraxia, sir, a neuronortmesis or an axonortmesis, sir.
So when will you get burning?
So neuropraxia, sir, we might get, sir.
Okay. So come up with more common ones, yeah. You get a hematoma, you get a seroma, you get infection, you get recurrence.
Yes, sir.
Don't you get it?
Yes, sir.
You get scrotal edema.
Yes, sir.
Right. So these are the common ones. Okay, you said seroma. How do you manage a seroma?
Sir, initially we can go for repeated. Most seromas don't need to be managed, sir. They can be managed conservatively without doing anything, sir. If
How
at
long?
all the-
How
if-
long? How
Sir?
long do you leave them? How long do you leave them?
So up to 3 months, sir, we can leave, sir.
Okay.
And then if the seroma persists, then we can go for aspiration, sir, of the seroma content, sir.
Okay. What about a hematoma? How do you differentiate between a hematoma and a seroma? You come the next morning or a couple of days. What do you
There
see?
will be skin discoloration if there was a hematoma, sir.
Right.
Whereas in a seroma, there won't be any skin discoloration, sir.
Right. So how do you manage a hematoma then?
So hematoma can also be managed conservatively, sir, or else we can evacuate. We have to evacuate the hematoma, sir. If it is a small hematoma, it can be managed conservatively, sir. Otherwise, we have to evacuate and then secure the
What's the
bleeding.
danger of leaving a hematoma behind?
Infection, sir.
Right. More important that your mesh can get infected.
Yes, sir.
You know, what is
Sir,
the commonest location of injury to the ilioinguinal nerve?
Sir?
When you're doing open surgery,
Yes, sir.
what is the commonest site?
Where do you injure them?
Step where you get the ilioinguinal nerve injury.
So while opening the inguinal canal, sir.
So at what point you will get it?
So just after the incision in to the external oblique epineuritis to open the inguinal canal, sir.
Where?
The upper leaf, lower leaf.
So the lower leaf, sir.
Wrong, the upper leaf.
But
Penetrates the upper
actually it is at when you're opening the superficial ring.
Yes, sir.
When you are making an incision for opening the superficial ring, that is the commonest site of the injury to the ilioinguinal nerve. What are the various nerves you encounter during the open surgery and during the lap surgery?
During the open surgery, we'll encounter the ilioinguinal nerve, sir, and we will encounter the testicular nerve, sir. The testicular nerve to the testis, sir.
What is that?
Which
the
nerve is
testicular
that?
nerve, sir. Genital nerve. Genital branch of genital femoral nerve, sir.
Yes. And third,
Whereas in laparoscopic surgery, we'll encounter, sir, the
three
femoral
nerves,
branch.
3 nerves in open, 3 nerves in lap.
Sir. So in laparoscopic surgery, lateral cutaneous nerve of thigh, femoral branch of genitofemoral nerve, as well as the femoral nerve, sir.
Okay.
And in open surgery, sir, we can find the ilioinguinal nerve, sir. We can iliohypogastric nerve as well, sir, and the genital branch of the genitofemoral nerve, sir.
Right. Now, when you're doing the Liechtenstein operation, open operation when you're doing, what are the various special precautions you take when you're putting the mesh?
So We have to extend 2 centimeters medially to the pubic tubercle.
Good.
We have to make sure that the mesh is of adequate size and is covering both the
What is
floor
that
as
adequate size?
sir. 3 to 4 centimeters overlap should be there, sir.
Where you do the overlap?
So beyond the boundaries of the canal, sir.
But can you go 4 centimeter beyond the pubic tubercle?
No, sir. Which is why the aim is to go 2 centimeters beyond the.
So you medially you go only 2 centimeters.
Yes, sir.
Inferiorly
Laterally
you
we
go
can
up
go,
to,
sir.
inferiorly
Laterally
you can
and
go up to
inguinal ligament, sir.
inguinal ligament. Superiorly how much?
So 4 centimeters and
And
laterally
how
as
much?
well 4 centimeters.
Laterally?
So up to the A size, sir.
4 to 5 centimeter lateral to the deep ring.
Yes, sir.
Okay. And then what else special thing you have to do?
It has to be the mesh placement has to be tension free, sir.
Okay.
And
What you do to the deep ring?
so the deep ring, if suppose the deep ring is dilated, sir, we can do a repair of tighten the deep ring, sir, and we can do lateralization of the cord, sir.
Do you make an artificial deep ring or not?
Yes, sir. We do make an artificial deep ring, sir.
That's a part of that, you know?
Yes, sir.
That you have to make an artificial deep ring from
Deep
the
ring
mesh.
with the mesh, sir.
Okay. Can you get a patient of hernia where he is having the strangulation but there is no obstruction?
Yes, sir. In case if the content is omentum, sir, there might be strangulation without obstruction, sir.
Any other reasons where there may be strangulation but no
So
obstruction?
in case of a Richter's hernia, sir.
Yes. Okay. Richter's hernia. Yes. Anything else? Appendix is the content or mucus is the content.
Yes, sir.
They may be
We
gangrenous.
remember
No
strangulation.
obstruction.
Yes, sir.
How do you clinically diagnose a sliding hernia?
Not sure, sir.
Hmm?
I don't know, sir.
If you get a real big hernia, which you are not able to reduce, always suspect the patient is having a sliding hernia.
Yes, sir.
Okay. What is inguinal hernia?
So persistence of pain after a hernia operation is inguinal hernia, sir.
So after 1 week of
After
the
3
surgery?
months, sir. After 3 months of surgery of inguinal hernia, sir, if the pain persists, is known as inguinal hernia.
What can the cause for that in inguinal hernia?
So the cause could be, sir, either nociceptive or neuropathic, sir. If it can be due to the physical characteristics of the mesh, sir, or it might be due to damage to the nerve, sir.
What
Have
is
you-
hydrocele of hernia?
Sir?
What is hydrocele of hernia? And what is hernia of hydrocele?
So hydrocele hernia would be, sir, if there's a seroma formation around the mesh, sir, it would lead to a fluctuant swelling in the area of the hernia repair, sir.
So hydrocele of hernia is in the inguinal region. Then why should you call it hydrocele? And what is hernia of hydrocele? What is the recurrence rate of the operation that you're describing?
Sir, I think it's less than 3%, sir.
Of what? Which operation?
Open, sir, open repair, I think it's less than
And
3%.
laparoscopy?
I'm not sure, sir. For laparoscopy.
Which operation has the least incidence of recurrence in the literature?
Lichtenstein's tension-free mesh repair, sir.
That is 3% according to you. There's an operation described in the literature which has incidence of recurrence as 1%. Can you name that operation?
So Scholdi's repair, sir?
Very good. Fantastic. And in Scholdi's repair, do you use a mesh?
No, sir. It's a herniorrhaphy, sir.
Bolo. Isn't it paradoxical? In laparoscopy, we are using mesh.
Yes, sir.
In Liechtenstein, we are using mesh. None of those operations have a recurrence rate of 1%.
Yes, sir.
So, what's the take-home message?
So, Scholdi's repair has to be done in the hands of a skilled surgeon, sir.
Very good. So, in the hands of average surgeon, what is the recurrence rate of the hernia that you mentioned, of the operation that you mentioned?
Not sure, sir.
It is 10%.
10%, sir.
हाँ, कहाँ 3% बोल रहे? You're flattering
10%.
everybody. 10% is the average
10%.
recurrence rate. So, all repairs with mesh are not necessarily very good. Okay. Just like all stapler anastomosis of intestine. Do you think stapler anastomosis of intestine has no leak? What do
No,
you think?
sir. No, sir. They do have leaks.
Even staplers leak.
Yes, sir.
And hand sewn anastomosis also leak.
Yes, sir.
Yeah. So that's the wisdom. So which operation will you select?
So I would go for a open hernia repair, sir.
Your bosses will get angry with you. They do all laparoscopy. What is the gold standard? In fact, I would like an opinion of the panelists. What is at present the gold standard for a inguinal hernia repair? Because on one of the hernia conferences and symposium, I was on the stage. So I asked the panelists, that before I utter something, I would like to know for my own knowledge, what is the gold standard as of today for inguinal hernia?
Currently, sir, the gold standard is the Lichtenstein tension-free mesh repair, sir.
I would like opinion of the other panelists, sir. Is laparoscopy the gold standard? My question to the other panelists.
I will come in here, sir, quickly. At this point of time, the word of gold standard, I doubt if there is existing at all. The options for the
laparoscopic cholecystectomy was the gold standard.
That is fine, sir. That is fine for gallbladder, not for inguinal hernia for sure. I have to tell you 3 important facts. The EHS says if you are knowledgeable and if you are fairly experienced, you can consider laparoscopic repair. But for the benefit of the students in India, 70 to 75% of the inguinal hernias are done still with traditional no tension mesh repair.
Yeah.
So let us say a student should learn the open method first. As he gains confidence, he can move to laparoscopic method.
Correct. True.
So that should be the safe approach, unlike your cholecystectomy, where 100% laparoscopy has taken over or replaced open operations. So if the student says, in my hands, I would do a safe mesh repair, I think I will accept without much of a challenge to him.
Correct, sir. That is for the exam sake. I am asking as a faculty.
And once he is able to show his proficiency, and if so, the department has the ability to train the student, not less than 60 laparoscopic operations to claim he is a competent laparoscopic hernia surgeon. That's the current message the EHS has given. So the student can, if he says, I think none of our co-examiners will disagree, I will do an open repair. And as the department where he gets trained, gets evaluation and train the students, I think he can consider to do a safe laparoscopic repair. That will be my statement. But let me also hear to the other seniors here.
Yes, but my question is something different. It's not for exam. It is not for training. It's okay. We are all learning the new technique. But as of today, is laparoscopic repair for inguinal hernia the number one procedure, or an open surgery is the number one? Is for my own information I want from my esteemed faculty. I'm not talking about exam. For exam, the student is right. I totally agree with you, what you said. But for my own knowledge, what is the current?
My point is that if it is a unilateral hernia is there,
Hmm.
whatever you say, the gold standard,
Hmm.
that is the Liechtenstein tension-free repair
Hmm.
for the unilateral hernia.
Yeah.
If it's a bilateral hernia is there,
Hmm.
then laparoscopy takes over the Liechtenstein repair.
Okay. Because there are complications with laparoscopy also. The complications which occur do not occur in an open surgery for the hernia, inguinal hernia. So okay, so a bilateral laparoscopy, but unilateral simple, probably open would be the number one. Thank you. Yeah, right. So Arnav, why does a hernia recur after any operation that you have done? Let's talk something about recurrent inguinal hernia. What are the causes of recurrent inguinal hernia?
Sir, it could be due to mesh migration, sir.
MS level, now we come back to academics, MS level. So tell me, why should a inguinal hernia recur? What are the causes?
So it can be due to migration of the mesh, sir. It can be if the since it can be if a very too small a mesh is used, sir, to cover the defect. Hello.
Yeah, I'm listening. I thought the classification or the explanation to that was pre-operative causes, operative causes, and post-operative causes. That's how I've learned and I've taught the students, you know.
So
Pre-operative cause,
pre-operative would be, sir, if the patient has any predisposing factors leading to the hernia, sir. Suppose if he has chronic cough, or if he has constipation, or if he
good,
has urinary symptoms, sir,
good.
that needs to be addressed first before going for the operation, sir.
You operate
that-
hernia without treating his enlarged prostate. Very good, correct. Or second,
Second, sir, intraoperatively, sir,
operative. There's one more thing, and that is wrong selection of operation. I mean, these are during the days when we used to do herniorrhaphy versus hernioplasty. Of course, nowadays we are putting mesh all the time.
yes.
But otherwise, if a patient's muscle tone was bad, and if you did herniorrhaphy, you are
It would
asking.
lead to recurrence.
Very good. Now the intraoperative. Tell me, what are the intraoperative causes for recurrence?
So if an inadequate mesh size was used to cover the hernial defect, sir.
He does that, at least in open hernia, so there's never a problem of inadequate size. So first reason was inability to ligate the sac at the correct position.
Correct positions.
What is that correct position?
So the sac has to be lifted and the contents have to be reduced, sir.
No, that
And
is
then
understood. Ligate sac where?
at the level of the deep ring, sir.
Ligate sac high.
High ligation of the
High.
sac, sir.
And that is at the level of deep ring.
Yes.
Very good. Then don't miss another sac. It could be a pantaloon and you're missing
Yes.
one sac. Then what else? I mean, this is now academic, like using absorbable suture materials.
So
Okay, come to post-operative causes of recurrent hernia.
post-operatively, sir, if the patient if there is infection in the infection or seroma formation within the
Yes,
which
very
is
good.
non-resolving, so that might lead to recurrence, sir.
Yes. And
Or if there's a hematoma formation which has to be drained, so that might lead to a recurrence, sir.
anything else? Lifting heavy weights.
So lifting heavy weights might predispose the patient to again develop a recurrent hernia, sir.
Yeah. So when will you allow the patient that he can lift heavy weights? He is a laborer. हम काम पे कभी जा सकेगा, डॉक्टर साहब?
So after 3 weeks, sir.
3 weeks is enough? You think the scar is mature?
3 months.
Right. Okay. All right.
Now,
So
one of the
that-
very important thing which is there, now you were talking a lot about the collagen disorders, collagen disorder. You know, what is the commonest cause of collagen disorder in relation to the
Smoking, sir.
hernia? Hmm?
Smoking, sir.
Sorry?
Smoking, sir.
Smoking.
Or tobacco usage, sir.
Yeah, that is the most important cause.
Yes, sir.
Okay. So
So
collagen
post-op-
disorder is not as such because of the collagen problem. It is because of smoking.
Yes,
There is
sir.
a disturbance in the collagen is there. And that is the reason, very important reason for the recurrence is there.
I mean, one other question is coming to my mind. Supposing inguinal hernia open surgery has been done and the wound has got infected. Are you following?
Yes, sir.
Infection होएगा, pus निकल रहा है, all that got cured with antibiotics and ultimately everything has closed down. So there is a lot of fibrosis, no, because of infection.
Yes, sir.
तो उसको recurrent hernia नहीं होना मांगते हैं ना, कि होएगा?
So it would lead to a recurrent hernia, sir, because the mesh will also reduce in size, sir, and so it won't cover the defect adequately, sir.
Oh, that is the reason. What is the laudable pus? Have you heard of it?
No, sir.
You heard of pus?
Yes, sir.
What is laudable pus?
Not sure, sir.
There was a time in the history of our medicine and surgery where pus, appearance of pus, heralded cure and treatment. So that time ka surgeons, I'm going about hundreds of years ago in the historical background, there was a period where if the wound was not throwing out pus, it was considered a bad thing that this wound will never heal. So once the pus starts coming out, everybody would enjoy. So here where the pus is coming out from inguinal hernia, we are not enjoying. We are sad that it is becoming recurrent. The
Yes, sir.
reason is not the size of the mesh. The reason is the quality of collagen.
Yes, sir.
That is the reason.
Yes, sir.
Okay. Great, good. Nice discussion we've had. Nice presentation, Aruna.
Thank you, sir. Thank you, sir.
Other faculty, would you like to give their comments, sir, for this class?
I think Arnav has done very well, very well, very good.
Thank you, sir.
Very impressed.
Thank you, sir.
But some clinical tests you must do well properly. Okay, they will be
I
asked
will
to
read up again.
demonstrate.
You must know everything about hernia.
Yes, sir.
I have put up on the chat the books that I have written. You will find it helpful. All
Yes,
the
sir.
clinical signs mentioned in my book are those given by Bailey and Love and Hamilton Bailey's physical science.
Yes, sir.
Okay, so, I mean,
Sir, I will go back and revise all of it.
yeah,
Yes.
because you will be asked to demonstrate and then you are in a very bad situation because
Yes.
some examiners are nasty. They'll say, we don't want you to talk. You just show us how you're doing. And when you're doing it wrong, it could mean bad news.
Sir.
Right. Okay, beta. Take care.
Thank you, sir. Yes, sir. Thank you, sir.
Laudable pus is white pus due to, I got some answer from here. That's very nice. Due to staph
Yeah, I've done that.
onset of healing historically. Yes, true. That was a time when people used to contaminate the wound with all
Yes.
kind of dirty things so that pus
So
is coming out. Okay. Right.
Right. Good night, everyone. Thank you.
Thank you.
Thank you, sir.
Faculty, any other comments? Okay, I don't know. Do you have any questions to ask?
No, sir.
Thank you very much.
Thank
And
you.
with the permission of the faculty, can we call the session a close, sir?
Yes, sir.
Yes, sir.
Thank you, sir. Thank you, everyone.
you,
sir.
Thank you, sir. Good night, sir.
Good
Kanna,
night.
sir, I am arriving to Prayagraj on 4th. Hope you are there on 4th, right, sir?
Hello.
Sir?
Yeah, I'll be there on 4th. Yeah.
Yes, sir. We'll meet there, sir. Thank you, sir. Thank you. Good night, everyone.
Good night.
Thank you, sir.